Good morning, everybody, and welcome to the Strabismus and Neuro-Phthalmology workshop. We will have, as people are trickling in, some are still in breakfast, so we'll have a little slowish start. Of course, this workshop is a more interactive based workshop. We hope that we can get some question and answers also going. So these are case based topics that we are covering. We're going to cover all the various case scenarios that we can see, and in a case based manner. We will be presenting the case, giving a little bit about how we manage that particular case, and we will then open the house for discussion. So if there are any questions, doubts, it would be good if we can discuss that. And so that's how our format is. We are open to any questions, we are open to discussion. We'll be glad to have differing opinions to the way we manage, because it is always a collective learning process. First time this year onwards, we are having a host of international faculty also who is participating with us. So welcome Dr. Asha, Dr. Gunjan. They are our ex-senior residents trained here, but doing extensively wonderful work outside. We have some others also. Dr. Anita is here. So if they can come in front, our experts, that will be good. Of course, we have our host faculty, that is me, I'm Dr. Rohit Saxena, Dr. Swati, Dr. Rebecca, and Dr. Amar. And with us are our senior residents, Dr. Priyanka, Dr. Mrinalini, and Dr. Himani, who would be in this, along with some of our junior residents who would be presenting the cases and helping in the overall running of these sessions. So welcome everybody. I hope you find this workshop useful, productive, and I hope we have an interactive and useful day. So again, thank you everybody for coming to our workshop. We'll start with the childhood progressive myopia that will be presented by Dr. Rebecca, who's our faculty and has done extensive work in this topic. And I'm sure this is an emerging topic, unfortunately, and we hope to gain insights into how to manage and prevent this growing menace. So Dr. Rebecca, please.
Thank you, sir. Thank you for the kind introduction. So yes, as sir said, that myopia is it's a huge number, you know. And you can see that already the situation is alarming in countries like East Asia and Southeast Asia. In India, if you see, the prevalence does not seem to be very high. So we did this North India myopia study, and we also did a meta-analysis of the last 4 decades. So although the percentage-wise it looks less, but you consider the humongous population of the country. And that population, especially the younger population, so the numbers are actually staggering. And we also noted a near doubling of this prevalence in both urban as well as rural children in the past few decades. Now, it has multifold impact. It can lead to visual impairment and blindness. This progression can also have psychological impact on the child, and of course can amount to global productivity losses. So before I jump on to the management, just brush up the definition of myopia. So we all know myopia from the basic textbooks, that myopia is a refractive error with a refraction less than equal to minus 0.5 diopters. But the catch over here is that ocular accommodation should be relaxed. So that's why you cannot label a child as myopic unless you do a cycloplegic refraction, because the child could be accommodating and would be misclassified as myopia unless you nullify the accommodation. Then another new concept that has been introduced recently is the pre-myopia by the International Myopia Institute. So basically this is the group of children who are at a future likelihood of progressing to myopia. So how do you identify them? They have a less hyperopic refractive error or a little myopic as compared to their age normal counterparts. And the purpose of identifying this group is that if you want to start preventive interventions, you have to target this group. Now, when a child of myopia comes to your clinic, how should you work up the case? Relevant history, just focus on that. Age is important. Then what was the age of the parental history of myopia, if any? Whether single parents, both the parents, what type of myopia? Then child's visual environment, because these all contribute to the risk factors. These are the risk factors that can lead to myopia progression. That includes the outdoor activity. So less outdoor activity, more near work, more digital screen time, these are the risk factors. If the child is already myopic, then what was the age of onset of myopia? Then is there any history of progression in the past few years? And whether the child has used any myopia control treatments previously. In the investigations that we have divided and classified into 3 categories, but remember a must-do, because availability of instruments can be an issue everywhere, but the must-do investigation should be of vision, IOP, anterior segment, dilated posterior segment evaluation, and a cycloplegic refraction, either under tropicamide, homatropin, or a cyclopentolate, to avoid the chance of misclassification. Here, I would also like to add, you better add ocular biometry and axial length to your assessment, because that helps you monitor the progression of myopia. So just in brief, the risk factors that have been associated with myopia: genetics and parental history of myopia, younger age of onset, East Asian and South Asian ethnicity, they are at a higher risk. Indians as such a low progressing cohort, but still a rising trend is being noted. Baseline refractive error, if it's already high myopia or a higher as compared to the age normal counterpart, you would expect a greater progression, and of course the visual environment that I just discussed. So all these factors lead to failure of emetropization and peripheral hyperopic defocus. So something hyperopic defocus which is occurring in the peripheral retina, that's believed to be a stimulus for axial length elongation. Now the next question is, once you have worked up the case, do you need to treat every case of myopia? The answer is no. You have to do a risk factor stratification based on whatever you have assessed, and remember that greater the number of risk factors, greater the risk of progression. So if the child has minimal risk factors, no evidence of progression, just observe the child and keep under follow-up. The most accepted indication for intervention is the progression of more than 0.5 diopters in a year and presence of high risk factors, which I just discussed. If the child is a pre-myope, what do? Just do a basic refraction, keep the child under regular follow-up, and you can introduce lifestyle and environmental modifications, which would be increase the outdoor activity. So outdoor activity up to an hour or so, it has been believed to be quite protective in myopia progression and even onset. Reduce near work, decrease screen time, you create awareness about healthy digital screen behavior that the child should follow. Then if the child is myopic and you have to start myopia interventions, apart from these lifestyle modifications.
Adjust the amount of red and blue that you can see using an adjuster here. You move it right and left till you can just see the red or just see the blue while you're wearing the glasses. This is again based upon therapy where you're using, it's like these are different forms of games actually, whether this is a form of shooting or it's a form of crossing the road or driving on the road, or so some games where one of the eyes is getting a red stimulus, one of the eyes is getting a blue stimulus. You can also do this while patching, in which case there is not a red-blue differentiation. And then you also have this random dot stereogram concept, which is used for looking or improving your vergences as well as testing your stereo acuity online. This again is by a software called Binox, which is Singapore based, again is available in India. An indigenous software that has been developed is called CureC. Again, it is based on very similar properties. It's a combination of the Revital Vision Gabber patches as well as the Binox. You have these red-blue glasses which differentiate. You have a UI which looks like this. You can select one of these games here. Either the game is like a shooting game, you can see this red dot has to eat these blue dots. So one of the eyes is seeing the red, one of the eyes is seeing the blue, and you're stimulating them simultaneously, binocularly, and that again is a very important part of the concept now to increase the binocularity or the stereo acuity. So this is what is dichoptic therapy. It also uses a crowding phenomena interface where you have to select one or two elements out of a crowd or number of elements that are there. So again, this is claims to do very well. There aren't too many randomized control trials on any of these softwares as such. There are a few trials, but of a limited number of patients that are there at the moment. This is another software here by an Israel-based company, NovaSight. This is using two systems in it. One, of course, the dichoptic concept of red-blue differentiation. So this gives you a picture of something in the center that gets blurred out in front of the better eye, and only the amblyopic eye can see that based on whether it's on the red or the right or the left eye. And this is also based on an eye tracking system where that central object, a squirrel or something, will move around inside and you have to track it. And there is a tracker that is evaluating the patient, and based on how well he can track it, it knows whether he's able to see or not see that object. And it does a scoring system, and there is an AI which keeps on improving itself. So this again is home-based therapy that send it to your home and you can do the therapy and return the device to them. Another therapy here called CogniHab. This is one example of a couple of new things that have come, which are virtual reality-based therapies, where you have a patient who's wearing this VR goggles and you have a stimulation which is different in both the eyes, and there is the patient has to do a simultaneous macular perception to be able to see this. And then again, you can blur one of the images in front of the better eye, and so the amblyopic eye has to see the rest of the image. Or this image is presented only to the amblyopic eye and not to the normal eye. So based on how the child is able to see and follow these videos, the vision improves. These are all the advantage of all these therapies are that these are overall fun therapies for the child to do. There is no social stigma of patching and moving around. But unfortunately, what has happened is they have started to replace patching, which is not what their original intention was. It was actually to kind of supplement what occlusion therapy was doing, or to speed up the recovery. But they have kind of started to become standalone, and they are doing their job. There is of course a cost involved, from somewhere till about, let's say, 15 to 20,000 rupees for the patient for one cycle of therapy, going upwards to about 30,000 based on the the machine that you choose or the device that you use. And these therapies, of course, a major advantage has been that they are having a binocular stimulation, so the stereo acuity is supposed to improve. There is an improvement in the hand-eye coordination, so all these things are actually very helpful, particularly in the VR ones where you have a game that they have to play with their hands. So I think the take-home messages from the presentation are that that you need to be able to diagnose amblyopia. It is a diagnosis of exclusion. Make sure you rule out everything else. You need to the first line of treatment is refraction even today, or correction of the strabismus. And the issue with strabismic amblyopia is that you can't use these computer vision therapies because they both are assuming the eyes to be orthotropic or maybe slightly exoesophoric, but not more than that. Gold standard continues to be occlusion therapy. You can give them access to some of these computer-based or active vision therapies as of today to help speeden up their recovery. And thank you.
Thank you, Dr. Digvijay. Any comments or questions before we'll start the meat of the program on strabismus? Yes.
I would like to add one thing, that whichever therapy we are giving to the patients, it has not to be stopped abruptly. Even if we are giving occlusion to the patient, study at RP Center only has shown that occlusion has to be tapered off and it has not to be stopped suddenly. Second thing is the follow-up of the patients who are on occlusion. It is important in the initial days, especially. They have to be followed up closely to look for any reverse amblyopia which is happening. Sir, I would like to know your opinion regarding what is the maximum age up till which you are advising occlusion. And secondly, you have done a large number of studies on the medical management using drugs like citicoline and dopamine.
Yeah.
So what has your experience regarding the same?
Dr. Rebecca, you want to take that? She's the one who's been working extensively on our amblyopia. I'll just talk about the upper age limit, because there is none. I would say that just like today, if I relocate to France, I will have to learn French, and I will be able to, hopefully, not that I have any plans to, but similarly, amblyopia therapy is harnessing the neuroflexibility that still exists in the brain. The brain is able to neurons are still able to throw out dendrites and form interdigitations and connections with a pathway. So amblyopia essentially follows or occurs because of the neurological rule that any pathway that does not get used starts reducing its connections and stops kind of transmitting electricity. So that's all there is to amblyopia, and our aim is to start so all these interventions are, you can see, based on stimulating the amblyopic eye in some way or the other, and when the traffic in that pathway starts moving, you start getting a response in the cortex, and you'll start getting better vision and amblyopia therapy. So I would say anybody who's willing or interested, there is no age limit to amblyopia therapy. We've seen patients recover at much older age group also. So young adults or even in their 30s also have shown at least a line or two. The question is that relevant? Is that clinically or functionally significant? Now that is a question that none of these studies which you will read about, all these newer investigations which also talk about that it works in adults, don't answer. So they talk about 2-line improvements. Now if a patient starts with 6/60 and becomes 6/24 while the other eye is 6/6, you know that while on the paper it will look very good that there is significant improvement, but whether that becomes functionally important or not, and usually the visual fields anyway exist in these patients. Usually they have central scotomas, so the concept that the field will improve also is a little down, but I guess any improvement is improvement, and if the patient is willing to accept therapy, I think we should offer it to them with the caveat that the possibility is there. But more than actually the age, I think the starting vision is the more worrisome factor, because if it's like 2/60, 3/60, it's actually criminal to subject a child to blindness that it would be. So the hours he will be wearing occlusion in the better eye, the child will effectively be blind because his better vision at that time will be 2/60 or 3/60. So you need to be, again, like I said, be very interactive with the parents and children. So you can't let that child go anywhere with a patch. You need to make sure that he is under a very supervised, very close, very comfortable environment so he doesn't injure himself. So these are individual considerations that we need to take when we are advising therapy for amblyopia. And the second part, yeah, Rebecca, was...
So do you think increased hours of occlusion can help in older patients?
Total duration of therapy is what that counts. You do that in 10 days continuous, you do that 2 hours for 200 days. So essentially, yeah, earlier we used to be more, we believe, and theoretically it still sounds better that longer the hours of occlusion therapy, the faster or better it will be. But then there are taper off compliance issues, and also you need to see match between functional abilities as well as the benefit of occlusion. So I guess part-time occlusion has its definite advantage when improving compliance is concerned. So yeah, Rebecca, comments.
And I think as Sir was discussing regarding the dioptics, so we have a lot of projects going on. Dr. Swati is looking at the CureC, the results of CureC, and I'm just starting the project on CogniHab. So very soon we'll be having these results, and in fact we are also trying to look at what impact it can have on the older ages in amblyopia. So we are still underway evaluating the results of dioptics, but occlusion, yes, you should give a trial. You should definitely, as Sir is saying, do give a trial if the patient is willing, if the patient is compliant. So I think all these, within maybe another 1 or 2 years, we'll be publishing those results and we'll be more clearer about our outcomes then.
Citicolin.
So we've seen citicolin again here. We found that it tends to increase the speed of recovery, but does not have any final effect on the final visual acuity. Again, these drugs like dopamine also, they increase the neuroplasticity. That's how all these drugs are supposed to work. So eventually the result is the same, that you need to improve the conduction on the visual pathway system, and that will give results. So again, younger the child, the better it is. So younger children may not require these additional drugs, but if you're trying it in older patients, maybe it will be beneficial, that it will increase that neuroplasticity that will help us. So I think let's go on to the meat of the session now on strabismus. We'll have Dr. Vandita here, who's going to start the session on strabismus. So we'll have her talk on her case on infantile esotropia. Dr. Vandita.
Good morning, everybody. I'm Dr. Vandita Agarwal, and I will be presenting on the topic infantile esotropia. So a 4-year-old male patient presented to us with inward deviation of either eye since 6 months of age. There was no history of any perinatal insult or trauma, no history of any viral illness, but there was a history of similar presentation in his younger brother, as shown in the image over here. On ocular examination, the vision done by Cardiff at 50 centimeter was 6/15 in both the eyes. On refraction, it was compound hyperopic with the rule astigmatism, and we can see with the in the primary position with the right eye fixing and with the left eye fixing, we can see there is severe inferior oblique overaction graded as +3 in both the eyes. On squint examination, we can see in dextroversion and levoversion there is inferior oblique overaction, and there was a V pattern. On prism bar cover test, for distance it came out to be 60 to 65 prism diopter base out, and for near also it was similar, 65 prism diopter base out, suggesting that there was a normal AC by A ratio. This patient also had cross fixation of free alternation as shown in the video over here. So on levo version, we can see the patient is fixing with the right eye, and similarly in dextro version, the patient will be fixing with the left eye. So we made a diagnosis of infantile esotropia with inferior oblique overaction with V pattern and planned the patient for bilateral medial rectus recession of 6 mm and bilateral inferior oblique iliate and Nankin. This was the post-op day 1 picture. We can see that the patient is orthophoric. So coming to the characteristics of infantile esotropia. First, there will be a large angle esotropia, more than 30 prism diopters. There can be cross fixation or free alternation present. There will be no significant refractive error, no neurological defect. There will be associated dissociated vertical deviation, inferior oblique overaction, nystagmus. Our patient has inferior oblique overaction, and there will be asymmetric optokinetic nystagmus. There are two important variants that we should know. First is Ciancia syndrome, second is Lang syndrome. So coming to Ciancia syndrome, it will have infantile esotropia with nystagmus and abduction, with manifest latent nystagmus with bilateral abduction limitation. And in Lang syndrome, there will be a DVD with nystagmus and excyclodeviation of the non-fixing eye. So the differentials for a 6-month-old child with esotropia would majorly include infantile esotropia, accommodative esotropia, ESO-DRS, and 6-nerve palsy. First, coming to ESO-DRS, the amount of limitation will be more than the amount of deviation. And also it has associated narrowing of palpable aperture on adduction, globe retraction on adduction, associated upshoots and downshoots. And in 6-nerve palsy, the amount of deviation will be equal to the amount of limitation. To differentiate it from infantile esotropia, on doll's eye reflex, it will be normal in infantile esotropia, but there will be abduction limitation in the 6-nerve palsy. Accommodative esotropia, there will be ESO deviation, which will increase with accommodation, which will further be discussed by Dr. Ayush. Thank you. And also I want to thank the faculty for giving me this opportunity.
Thank you, Vandita. Maybe we'll go on to the next case also by Dr. Ayush, so that we'll club the esotropias together and then take any discussion or questions on that.
A very good morning to everyone present, and I would also like to thank everyone for this opportunity. So coming to a case of partially accommodative esotropia. A 5-year-old child was brought to us with the chief complaint of inward deviation of either eye since the last 3 years. She had a history of wearing glasses, and there was some improvement in the deviation noted while wearing these glasses. Her best corrected visual acuity was 6/6 in both eyes with a refraction of plus 2.25 diopter sphere, and the extraocular movements were full and free across all gazes with an inferior oblique overaction noted in both the eyes. So as we can see, for distance fixation without glasses, there is around 50 diopters of ESO deviation, which is then noted to be equal across all the 9 gazes. On prescribing a full cycloplegic correction, the deviation improves to some extent and reduces to 25 prisms diopter, and again it is the same across all gazes. On squint examination and measurement of the deviation using the prism bar cover test, we noted that the amount of deviation for distance without glasses was 50 prisms. The amount of deviation with glasses came down to 25 prisms. And for near with glasses, the amount of deviation was again 50 prisms. That is, there was presence of near distance disparity. On measurement of the AC by A ratio using the gradient method, it turned out to be high, that is 10 prisms per diopter. So as we saw, the distance deviation was 50 prisms. The near deviation was 25 prisms, and this was, and on adding a plus 3 diopters, near add to relax the accommodation, the deviation improved. So the key points of our case are an inward deviation of either eye, which partially improved with glasses, presence of a near distance disparity due to the high AC by A ratio, and associated inferior oblique overaction along with V pattern. So a diagnosis of a partially accommodative esotropia with inferior oblique overaction with V pattern was made, and the patient was planned for both eye medial rectus recession of 3 mm along with both eye inferior oblique weakening using the modified iliate and Nankin recession. This is the post-operative outcome of the same patient, and as we can see, the patient has turned orthophoric with glasses. So a child presents with history of inward deviation of either eye. What are the major differentials? As we can see, there is a long list which can at times be confusing. So to limit us to the major differentials of esotropia in a child, it can broadly be classified into comitant esotropia and incomitant esotropia. Amongst the comitant ones, we have infantile esotropia and accommodative esotropia. And in the incomitant group, we have the paralytic, that is the lateral rectus palsy, and restrictive, that is Duane syndrome. We shall be limiting our discussion to accommodative esotropia. So, accommodative esotropia is an esotropia which is caused due to increased accommodative effort or due to an high AC by A ratio. It consists of several subgroups which must be clearly differentiated because each requires a different clinical management. So, the first type is refractive accommodative esotropia, in which the esotropia is due to increased accommodative effort and it is turned to orthophoria at all distances and across all 9 gazes by simple optical correction. Hence, the management is to simply provide full cycloplegic refraction. So, this is an example of a refractive esotropia in which, as you can see, by simply prescribing glasses, the full cycloplegic correction, the child turns orthophoric. The next type is non-refractive or hyper-accommodative esotropia, in which the amount of ESO deviation for near is more than that for distance, and that is due to increased AC by A ratio. The treatment then is to provide a near ad, which compensates for the increased accommodation at near. Hence, the management is full cycloplegic correction with a near ad. And finally, the main topic of our discussion, partially accommodative esotropia, in which accommodative factors contribute to the ESO deviation, but there are other non-accommodative factors as well. And hence, the management is to prescribe full cycloplegic correction for the accommodative part and to target the residual non-accommodative component with surgical correction. And special care must be taken to counsel the patients that we are only targeting the surgical correction for the non-accommodative part, and the child would still require to wear glasses post-surgery, as otherwise they might expect that the child would be free of glasses post-surgery. Thank you.
Thank you, Dr. Ayush and Dr. Vandita, for covering up esotropia. So any questions or discussions, comments from our experts?
So one thing I would like to add is that whether it's any type of esotropia, there's a very high risk of the child getting amblyopic. So even if the child is waiting for the surgery, especially in cases of infantile esotropia, we should start them with patching, be it at least for 2 hours a day, so as the child does not develop any fixation preference of any particular eye and it remains alternate. Similarly, for partially accommodative esotropia, it's a good practice to start occlusion so that they don't develop strabismic amblyopia. Thank you.
Great, absolutely. Any questions or anything? We've just presented a couple of cases. We were hoping that we can get some discussion or other any issues that are very important point raised on amblyopia. Besides the risk of development of amblyopia, there is, especially in infantile esotropia, an abduction deficit or a limitation or problems in the eye moving from an adducted to an abducted position. So, which of course is an identifying feature for infantile esotropia that can be very easily seen on the OKN and sometimes also appreciated if you ask the child to follow. So you can see that the pursuit is smooth from abduction to adduction for either eye, but from adduction to abduction there is multiple breaky jerks that is there. So the pursuit is not well developed. So it is believed that an occlusion or an alternate occlusion, even in the absence of amblyopia, while waiting for surgery, as Dr. Gunjan has said, is a good idea, besides of course preventing the risk of development of amblyopia. So especially if it's often not easy to measure vision in a small child, so the best way to identify is the preference for fixation. So if there is one of the eyes has a dominance or is preferred for fixation, it's very, very likely that the other eye has amblyopia, and therefore the need for occlusion therapy is definitely there, but as Dr. Kunjan has said, to prevent. And of course in our setting where we work, there is a fairly long waiting time, so that the visual system does not change during the period of waiting. We definitely propound it, but yeah, there is usually some waiting for children that you get them evaluated by the anesthetist before they can be taken up. So therefore the definite indication to plan for to provide occlusion or give occlusion before we start. Any other comments, Dr. Asha?
So the alternate occlusion, especially in the cases where the visual acuity is a little less, like 6/18 in both the eyes and which is equal, do you think alternate occlusion is going to help with the visual acuity? And as you have said, it helps in smoothening the pursuit movements definitely, but do you think vision is going to change or something?
So alternate occlusion in the presence of strabismus, even in subnormal vision, Possibly yes. Like I said, it is to prevent further amblyopia and allow for allow for any one of the eye to become dominant. In the presence of aligned eyes, even if subnormal vision, I don't feel that alternate occlusion has any role. But yeah, in the presence of strabismus, definitely I think we should, if nothing else, to prevent further deterioration of vision, and of course stimulate either eye for a period, so it maintains the vision and probably improves it. Yes, any other comments? Anything anybody wants to, Dr. Swati?
As we were talking about occlusion, I just want to say one thing. Sometimes, infantile esotropia patients have cross fixation. So in those cases, even if you don't give occlusions, you are not doing any harm by, avoiding occlusion. So
possibly, I mean, one of the mechanisms, in fact, it is very surprising that infantile esotropia does not have amblyopia. You have a definite presence of misaligned eyes in a young child, the ideal recipe for amblyopia, but cross fixation is one of the ways which prevents amblyopia from developing, and you expect that while you are waiting for surgery, that mechanism remains. So again, everybody does not wholeheartedly approve the thought of alternate occlusion, but yes, it helps, especially in a younger child where you are not sure of fixation preferences. But again, that's a little that can be a little open to, but your decision has to be based on every child and what is the duration of waiting till the time you can align the eyes. And remember, it's not just surgery, it's alignment of eyes. So even as many studies have shown, 2 or more surgeries may be required in some children to reach alignment. So it's still alignment and not till surgery. So those are 2 different endpoints we must remember. So I guess we move. Any questions? It was very nicely highlighted that if a child comes to you with esotropia, a small child of a 2 or 3 year old comes to you with esotropia, your broad differentials were what we mentioned. So the first look is on motility. You check whether the motility is full or not. If the motility, if there is abduction deficit, your thoughts are 6 nerve palsy and Duane's. It's almost like I generally believe that it's Duane's unless proved otherwise, because the likelihood of a single nerve unilaterally being affected developmentally, that is just the maldevelopment of 1/6 nerve, is rather unlikely in the absence of any other neurological or any other developmental anomaly. So that's why I would always think it's Duane's unless proved otherwise. And if it's comitant, then you need to do a full cycloplegic refraction before we can diagnose as a commutative esotropia, and of course infantile esotropias are the other diagnosis. So we'll welcome our chief, Professor Tityal, who is very busy today, but was willing to take out some time to just welcome you all to this center and address the gathering and give us a few words. I'll request Dr. Achal to please present Chief with a small feng shui, just to show that how we have been seeing our center grow, develop and come alive in his leadership. Thank you, sir, for coming. If we can request you for a few words, sir.
Good morning to all of you, and as the morning began with welcoming you to RP Center, and same holds true for my side also. On behalf of myself and the entire family of RP Center, you are all welcome to this very, very interactive session on strabismus and neuro-ophthalmology. We, as has been doing for a large amount of time, in terms of giving some sort of skill transfer to people coming from not only from the institutions, from a private practice, and it's been going on for ages. Since the RP Center was incepted in the 60s, there has been a constant effort from a institute to give a some sort of dimension to the teaching, and that has changed so much now, because in every decade there's a new thing coming up. But as far as I am concerned, for me, squint and Neuro-Phtha is same as what I used to see during my residency time. And I used to be, at least, 50 feet away from that area. To me, it look like, physics for me, like squint workup and doing assessment and doing surgeries. Thankfully, I'm in anterior segment. But I know that this is the area where we have to take people not only from the point of view of making them comfortable, but it is the time where we have to give them a vision. That is a binocularity of people, right from the onset of birth to the adult onset. There's a squint happening in a late age also. Every age group of people will be coming to us for these deformities, disorders, and if we give them a treatment right on time, we can prevent the blindness. We all know squint or amblyopia can cause a silent blindness in our people. Many parents don't realize when they come for a medical examination, that time they realize they can't see with the one eye. So that has been a factor in our country. I've seen many patients coming to me after 14, 15 years, 20 years of age. Some doctor had told them, okay, wait for 6-7 years for getting squint surgery done, which is a very poor concept, which is going across the medical fraternity also. Like Dr. Rohit nicely pointed out in the morning, there has to be Rebecca also. There has to be awareness not amongst us, awareness amongst the entire medical fraternity, as well as the school-going children. They require a basic structure for our school screening programs. The teachers should be oriented for our vision deformities so that we can take care of them in an appropriate time. As far as squint is concerned, I think the timing is a very important factor. And I know that we have been stressing on doing a good refraction in all these people, but I think the most effective refraction has to be done in this age group, especially with a squint or people suffering from some sort of refractive error. For last few years, since I took over, there has been a constant effort to change the concepts. So this year we are modeling ourselves to specific programs, labeling to one particular area so that you go with the concentrated knowledge in one particular field. The squint is one area where I know everybody wants to learn something, and we'll have Rohit and the faculty have designed very nicely the case-based presentations, which will take you through the appropriate management of one particular case. Subsequently, we'll take you to the various squint labs, workup areas, so that we know that what all instrumentations are there, how to handle those. At least gives you some incentive to do future studies or work in these areas. This year also, it was our effort to have our alumni people coming to our workshops. And I sincerely like to thank all of them. We had retina workshop also, and we had people coming there also. Today I see a lot of them are here. And in fact, alumni in this field are quite less. So but thank you all of them, Digvijay, Anita, Gunjan and Asha, they're all there. Thank you coming for this particular workshop, making RP Center as your own place, because people do have the feeling of RPC alumnus feeling, but the physical gathering is sometimes missing. So this is one opportunity where people can come, because it's not only that they have done a residency here, they have become a teacher of their own. They are in a various institution, they are doing a big practice where they are serving the community. Their experience should be shared by our students also. So this will be a very good interaction of people who have gone out of this place, have become a big people, and they are teachers themselves. Why not to take their expertise to a newer generation of people also. Like these people are 10, 15 years old, some of them are 4 or 5 years old from RP Center, and gives you a wide range of experience. That is what I want people to share with younger generation. You be with these people, interact with these people. Maybe this new concept will bring people towards RP Center. Not only the alumnus, the other people also. I know that many people will desire to be in a mode where they get actual training, which is very difficult to give in a one-day programs. So we do have short-term training programs. We can have observership for people. They can all come, see areas, visualize themselves how they would go through those areas, and future they can plan in similar ways also. This is a place where we have everything. So you require vision to see all those things which are placed here. Sometimes we miss out. and we realized we didn't see that particular thing which was there. So younger generation must see the things which are hidden also, which is not visible. Unless you know the thing, you will not see those things also. So that is a very important point. So I again like to thank the entire faculty, especially Dr. Rohit, Rebecca, Amar and Swati, because we have the group which works very hard, lot of workload in this area, and the SRs and JRs for making this workshop interactive. I hope all of you gain something. Please do give us feedback so that we can improve further, because this is the continuous education program, and it will depend on how people receive the program and how they actually want us to improve in the subsequent few workshops going to come this year and next year also. Again, thank you, the entire faculty, and especially the our own people coming from different parts of the country. Thank you again, and wish you all the best.
Thank you, sir. Thank you very much for these wonderful, encouraging words. I'll just request you to please give an RP Center memento to all our international able speakers who are there from all over the country. So, yes. So, Dr. Achal will be handing over to sir for giving the vlogs. So, Dr. Gunjan, please. Dr. Gunjan has come all the way from Bhilai to be a part of this meeting. And it's an absolute pleasure to have you back here, Dr. Gunjan. Dr. Asha, she's come from Hyderabad. This is just a small memento so that you can remember your visit back to RP Center. Dr. Anita, she works in Gangaram here in Delhi, and again, thank you for coming. Yes, sir. Yes, sir. Thank you. Dr. Digvijay. Oh. And Dr. Digvijay, he's has his own clinic at Noble Eye Clinic in Gurgaon. Again, in past president of UC, extremely active clinically as well as in other areas. So thank you. Two of our faculty are yet to come, so maybe we'll give them later. So I think we'll move on with the rest of the program. So thank you, sir. And now we'll move on to the next topic, which is intermittent divergence squint. As I have mentioned, that you have any questions in your mind at any time, please feel free to ask. It's the purpose of these sessions being case-based is so that it can be interactive. I'll request Dr. Beju to give his presentation on intermittent divergence squint.
Okay. Good morning, everyone. After listening to isotropias, I will be discussing a case of intermittent divergence squint. So coming to the history, here is a 17-year-old male patient presented with chief complaint of intermittent deviation of either eye, just noted since last 3 years, and there was blurring of vision at distance. His best corrected visual acuity was 6/6 in both eye, and refractive error was not significant. NTS segment examination was within normal limits. On fundus examination, as we can see, there was a cyclotorsion in both eyes, left more than right. On orthoptic examination, there was no head posture. On Hirschberg's, there was exotropia of 30 degrees, and Begolinis, there was a crossed response, and near end dot was 70 seconds of arc. On ocular movement examination, they were full and free, and there was bilateral inferior oblique overreaction. As we can see in this picture, when the patient is fusing, there is no deviation at the primary gaze. But when did the cover test and break the fusion, we can see the exodeviation getting manifested. So its distance end dot, there was no stereopsis. And 9 gaze, we can see in the up gaze the deviation is more, suggestive of V pattern. On dextro versions, we can see that there is an L by R, and on levo version, we can see there is an R by L because of the bilateral inferior oblique overreaction. And tertiary gaze, we can also see the inferior oblique overreaction. So we did the prism bar cover test, and we see that the distance and near deviation both were 45 prism diopters in the primary gaze, and there was no near distance disparity, which is suggestive of a basic pattern of IDS according to the Burians and the Kushner classification. On up gaze, the deviation was 55 prism diopter at distance, and down gaze it was 30 prism diopters, so there was a difference of more than 15 prism diopters suggestive of V pattern. So we calculated the modified Newcastle score, and there was poor home and clinic control, both were poor, and the score was 9. So we planned a left eye LR recession with MR plication with bilateral inferior oblique recession, modified Elliott and Enkins procedure, and these are the post-op pictures. So how to approach a case of intermittent divergent squint? The first thing is to measure for the distance and near disparity. If the distance deviation is equal to the near deviation, then it is a basic type of intermittent deviation, a divergent squint. If the distance deviation is more than the near, then we should do a patch test. After the patch test, if the disparity disappears, then it is a case of tenacious proximal fusion. If still the distance deviation is more than the near, then tenacious proximal fusion is absent. In that case, we have to apply +3 diopter lens and check for the AC by A ratio. If the AC by ratio is normal, then it is a case of proximal convergence. If AC by ratio is high, then we should counsel the patient for the bifocal use even after the surgery. If the near deviation is more than the distance deviation, then again we have to do the patch test. If the disparity disappears, then it is a case of pseudo-convergence insufficiency. If the distance deviation is still less than the near deviation, then it is a case of true convergence insufficiency, and we should advise patient for the convergence exercises. Now, not all the patient of IDS require surgery, and there are a few indications in intermittent divergent squint for surgery, and these are deviation manifesting more than 50% of times, when the IDS is progressed from Calhoun stage 2 to stage 3, when there is complaint of diplopia, worsening of distance stereo acuity, and when the IDS reaches stage 4, which is, in that case, we can do a cosmetic surgery. And what is the ideal time of surgery in IDS? So we have done a thesis and found that to achieve good sensory outcomes in IDS patient, surgery should be done before the modified Newcastle score worsen to more than 5. Thank you.
Thank you, Dr. Beju. So any comments before we take on a few questions? Sir, if we could just trouble you a little more. We have another faculty who has just come, Dr. Gazella. Congratulations, Dr. Gazella, for joining RML Hospital as faculty, and so welcome back to RP Center. We hope to be seeing. Just cover that. So we hope to be seeing a lot more of you since your return from Hyderabad. Thank you, sir. Thank you very much. Yes, Dr. Gunjan.
So one thing was about the surgical planning in patients of IDS, especially in children. They need to be undercorrected a bit because, again, exotropia, some residual exotropia is sometimes better than the child being overcorrected and going into esotropia. So I think undercorrection of 10 to 15 should be planned accordingly. 10 to 15 prism diopters should be planned.
No, I don't think so. I don't agree with them.
So,
what do you think?
So, yes, so there are two different, so both of them are actually giving us two different concepts. The problems, in fact, I wanted to start by saying that intermittent divergent squint, in my opinion or in my hands and what I feel, is the toughest of all surgeries to do. It is probably easier to manage third nerve palsies and Duanes and things like that because your outcomes and your hope and expectations are rather limited. But when you are dealing with intermittent divergent squint, the only real problem that the child has and the parent sees that it is occasionally deviating only, and more often than not there is fair amount of binocularity. So it's like, operating LASIK at 6/9, unaided 6/9. So there is very little you have to improve. Whereas, operating a third nerve or a Duans, it's like, operating an unaided vision of 3/60. So unaided is going to still be better, way better. So they're going to be satisfied and happy. So, so just saying that the problems with intermittent divergent squint is that you have little leeway. In a younger child, as Dr. Gunjan is pointing out, our risks of overcorrection are tremendous. Conventionally or notionally, I would say, concept-wise, intermittent divergent squints should be slightly overcorrected. In fact, most studies, including one done from here, has talked about that you should have an overcorrection of about 8 to 10 prisms. So you plan for a slight overcorrection. But that is true for adults or older children in whom the risk of amblyopia is on the lesser side. So maybe above 6, 7, 8 years old. For younger children, the risk of consecutive ESO, if it does not, the reason why is that one, they will have adequate fusional divergence, so over time they will correct themselves, and also that all intermittent divergent squints post surgery would have a little exodrift, which will catch that deviation, and you know that there is, we believe that on an average the drift is between 8 to 15 prisms, so you'll be able to catch that drift and not have a residual over a long period of time. So like I said, in adults, in older children, you are aiming for a slight overcorrection. In a younger child, that consequence of having an overcorrection or a consecutive esotropia with its risk of developing amblyopia is very, very problematic. Therefore, we are all very conservative, or I would say very careful in operating younger children with intermittent divergence. In fact, there was initially a thought that do not operate IDS before 4 years of age. Again, many of these children will have fairly good fusion. In a sense, they will be controlled because of not fusional vergence, but accommodative vergence, because they are almost always a little hyperopic and they can accommodate and control their deviation. So all of us who, in fact, myopes who are exophoric, all are controlling our deviation or the tendency of the eyes to drift out by our fusional vergence. There is a deficiency or a reduction in these children who are intermittent divergent squints in their ability to do fusional vergence, and therefore they start breaking. But younger children have a good accommodative reserve and also are often hyperopes. Therefore, they are able to control this intermittent divergence tendency by accommodative vergence. And that's how one of the interventions that we do in these smaller children is undercorrect their hyperopic correction so that we find them to be controlled. So yes, it's a difficult trade-off between what to do, but probably in a younger child, I would hope and expect that I may undercorrect his hyperopia, may leave him slightly undercorrected, undercorrect his hyperopia, that is, give him a lesser plus power and plan for a fusional vergence. Eventually, what's going to keep him aligned is his fusional vergence. And may plan an overcorrection in an older patient who probably maybe even be myope. So a myopic, a young adult, plan overcorrection. A hyperopic small child may plan optimal or slight undercorrection. So that's how we go, so that we are safer and can sleep more comfortably at night. I mean, I've had patients who are overcorrected, are complaining of diplopia, and every time I see them in the OPD, I'm like scared that what's going on. So again, a very important discussion on our endpoints of surgery. So any other comments, points to say? Yes, please. Can we have the mic so that people who are online connected can also hear what the topic of discussion is? Early post-op diplopia. So early post-op diplopia actually is a very good sign. We encourage and we are happy with the idea of early post-op diplopia if I find it is overcorrected. I mean, like, patient is going to complain if he is overcorrected.
Sir, age 25, 26 and
so again, older the age, the happier I am actually that he has diplopia. Younger the age, I don't think he has a very strong or deep suppression scotoma that he has. So most likely patient is going to complain of diplopia because of a slight overcorrection, because he's past that scotoma and now he's able to appreciate on his nasal hemifield. Usually, as I said, we ask these patients to follow up, because up to 1 to 3 months there is an exodrift in these patients who are basically inherently divergent squints. So there is a chance of overcorrect of a drift that will catch and will be corrected. So over time, our only aim is to kind of reassure them, tell them to keep going, especially if they may have a slight abduction deficit because of weakening of the lateral recti. So you ask them to do abduction exercises, ask them to use their eyes as much as possible. So we expect, as I said, that drift and the fusional vergence to actually catch that. But if it is a very significantly large overcorrection, maybe say above 15 prisms or so, he may remain an overcorrected patient with complaint of diplopia, in which case you need to take a call. So about 1.5 to 2 months, I still see there is significant overcorrection. Either for some time in a younger child, I would probably give 1:1 patch so that I do not develop amblyopia. Again, small deviations, you can think of giving a prismatic correction, so that, where the overcorrection is say between 8 to 10 prisms, you could give them a prismatic correction so that they overcome their diplopia. And otherwise, by 2 to 3 months, if I still have significant overcorrection, I would plan for resurgery. So that's how one would plan. Early significant overcorrection, intervene early, because you know that your drift is going to be only about 10 to 15 prisms, not more. And as I said, older the patient, post-op diplopia is a good sign. You encourage them because it's showing there is binocularity. The absence of diplopia, you're never sure whether the patient is now binocular or is still monocular as he was during the intermittent divergent phase. So,
So 6 to 8 diopter, how much time we need to wait?
6 to 8 diopters, I would definitely wait for 1.5 months to 2 months at least before I think in terms of
So we can
any form of
give
intervention.
him slight hyperopic correction to make him comfortable during that time, or not required?
No, I don't think, I mean, if a patient is not, then it really is not. I mean, you give them the optimal correction that they have.
No, otherwise.
If they don't have any glasses, they are not going to comfortably tolerate any kind of thing. So I would suggest that we should wait. If it is initially interrupting his function, and you feel that because of that the patient is complaining that he is unable to do, I would rather give him alternate occlusion to allow for the eye to abduct, to gain the abduction saccades, so that the muscle catches up and you are able to get that divergence in place.
And sir, even after 1.5 month also it remains thin.
Then, like I said, prisms, if it's a small angle,
Less than 10.
less than 10 prisms, a small angle, your comfort zone in surgery is less, and prisms do very well as far as that is concerned. So, and it's a comitant squint, so your deviation is virtually same in all gazes except in the abducting direction. So prisms work very well, and if it's more, then plan for surgery.
Also, persistent diplopia can be there in patients with central fusion disruption syndrome, especially in patients who underwent RTA. So they might have persistent diplopia for a very long period of time, even for their entire life, and they might blame the surgery also sometimes for that.
Absolutely. We've had patients who have come back and asked us to undo their surgery because they are extremely painful. Yeah, so post-trauma, divergent squints, particularly paralytic also, because there is multiple site trauma, there is a possibility that the patient may not be able to fuse. You need to check these patients with prismatic correction pre-operatively if it's doable. Sometimes it's such a large angle that putting so many prisms in front of the eye reduces the vision to such an extent that the patient does not experience is not able to see both eyes, so it does not complain of diplopia. But as I said, you need to check them. There is always the risk that the patient may complain. Often we are not in these kind of post-trauma, we are also not always bang on. So some amount of residual deviation may remain, and that may be responsible also. But even if we are absolutely appropriate, patients may not be able to fuse, although may keep complaining of diplopia post-operatively. So I think we'll change gears, and we've talked about trauma. So let's go on to paralytic strabismus. We'll have Dr. Priyanka, who will be talking to us about one of the most difficult of all paralytic strabismus to manage, oculomotor palsy.
Good morning, everyone. So I'll be talking about oculomotor nerve palsy. Moving on from the comitant squints to the incomitant squint, though both can be differentiated based on various features, type of onset, age of onset, any difference between the primary, secondary deviations, diplopia, or any face turn, or any associated history of trauma. So here are a few cases. Case 1, which is a case of a 13-year-old patient with exodeviation of the left eye, and there was a mild ptosis since birth. The BCVA in the left eye was 6/9, and there was an encyclotorsion present on the fundus. So this is the clinical picture which was taken at the time of presentation. We can see that there is a exotropia, there is a elevation, limitation in elevation, there is mild limitation in adduction as well, and so we diagnosed the patient as left eye congenital complete pupil in sparing oculomotor nerve palsy. So we did a FDT for lateral rectus, which was found to be free, and we went ahead with left eye LR recession of around 12 mm and a MR plication of 9 mm and a PTSO. These are the post-op images, and we can see the patient is pretty much well aligned. Next is a case of a 54-year-old patient who presented with a post-traumatic onset diplopia and ptosis, and these are the presenting pictures, clinical pictures. We can see that the right eye, there is a exotropia, there are limitation in elevation, and there's a mild limitation in adduction, but we can see that there is a change in the palpable aperture in adduction, which so we made a diagnosis of a post-traumatic third nerve palsy with an aberrant regeneration for this patient. Now we want to make use of this aberrant regeneration. So we, with the consent of the patient and after explaining the patient, we did a FDT of the right eye LR, and which it was found to be free. But we operated on the left eye, and the left LR resection of 12 mm and an MR resection of 6 mm was done. In the post-op, we can see that the patient is aligned, and also there is a correction of ptosis. The third case is again of a 15-year-old patient with an exodeviation of the right eye with severe ptosis since birth. The visual acuity in the right eye was 2/60, and there was an encyclotorsion which was present in the fundus. The pre-op or the presenting picture shows a severe ptosis, exotropia, the elevation deficit in both adduction and abduction, and there is a limitation in adduction as well, and dextrodepression. So diagnosis of a right eye congenital complete pupil in sparing third nerve palsy with a mixed amblyopia was made here, and after doing the FDT for the lateral rectus, which was largely free, nasal transposition of split lateral rectus was done with the posterior tenectomy. And these are 6-month post-op picture of the patient. The patient is aligned and is wearing a crutch glass. So the patient was happy. So we all know the anatomy of the oculomotor nerve, and so it originates at the level of superior colliculus in the midbrain. So it can get involved by the various lesions, starting from the nuclear, the fascicular, the basilar, the cavernous part, then coming on to the superior orbital fissure and the orbits. The important thing is to remember if the patient present with a painful pupil involving complete third nerve palsy, posterior communicating artery aneurysm, where aneurysm at the junction of posterior communicating artery and internal carotid can compress the nerve. Now the oculomotor nerve, it supplies all the extraocular muscles except the superior oblique and the lateral rectus, and the intraocular muscles, ciliary muscle and the pupil sphincter pupillae. So complete third nerve palsy, the eye will be down and out, there the pupil will be non-responsive, and there will be ptosis. So the initial approach to any paralytic strabismus is to first localize any neurological lesion, to manage that underlying cause, also to identify any systemic diseases such as diabetes and hypertension. And after ruling out all these, we have to follow up the patient at 6 weekly interval till 6 months, or at least 2 consecutive 6 weekly follow-up, which will show that the deviation is stable. And then we intervene if there is a presence of diplopia in the primary or down gaze, or there is a anomalous head posture. Non-surgical therapy we prescribe for diplopia, to avoid diplopia, and for the interim period. So it can be in the form of occlusion, a temporary Fresnel prisms, or a botulinum toxin to the ipsilateral antagonist muscle. And surgical therapy is indicated if there is a failure of these conservative management, large deviation and stable deviation with no improvement in 6 months. So these are the 4 steps before we plan any interventions. First, we look at all the version inductions and we do a cover test and measure the deviations. Then we look at the saccadic eye movements. We go ahead with an FDT, and if the FDT is free, we do a active force generation test to look at the for the strength, any strength in the paralytic muscle. This is a summarization of all the management of oculomotor nerve palsy. So for a complete oculomotor nerve palsy, if there is a good MR action which is present, we can go ahead with a LR resection procedure, And in case of a poor or a weak action, we can go ahead with the transposition procedure or globe fixation procedures. It can be in the form of LR periosteal anchor plus large MR resection, globe anchor to the medial orbital wall plus large LR resections, and lateral rectus transposition to the medial rectus. For the partial, we have to look for the muscles which are involved and which are spared, and accordingly we plan our surgery. And for aberrant regeneration, as we can use the fixation duress to correct both deviation and the ptosis. So thank you.
Thank you, Dr. Priyanka. Any comments? Yes.
Sir, lateral rectus periosteal fixation, do you think there are any chances of recurrence post-surgery? Like residual exo comes back or something?
So, of course, you need to be very selective in your cases when you're planning. So you plan that when you have a large, strong, large exo with the lateral rectus being very significantly stronger than a very weak but a perceptible medial rectus action. So in those conditions, you would plan a lateral rectus periosteal fixation with a very, very large medial rectus resection or plication. So, so recurrences can occur if you plan in a patient who inherently did not have good medial rectus function. So if there is very poor medial rectus function, you've kind of tied a rope tightly, but over time that tendency of the eye to drift out will stretch out that poor muscle, which is just like a tendon or just like a rope, and will drift itself out. If there is moderate medial rectus function, this surgery is likely to be successful. The other risks people talk about is that the lateral rectus may actually go back and stick to the sclera, which is less likely if you actually stitch close the compartment. So if you are able to close the denons over the muscle that you've sutured onto the periosteum, it's little less likely. So the recurrence is more likely, or even poor outcomes are more likely if you do not have good medial rectus function, in which case you have to think of alternate procedures like medial anchor of the globe to the medial periosteum, or the nasal transposition of the split lateral rectus. So these would be, so very poor medial rectus function, think of these two options, medial anchor or nasal transposition of split lateral rectus. The nasal transposition is only possible if your FDT is free or your lateral rectus is not very tight. If there is some medial rectus function, you can plan the periosteal fixation of the lateral rectus with a large medial rectus plication. And if, as we saw in the two cases, there is fairly good medial rectus function, the eye can actually tend to cross the midline, then you would think of a supramaximal recess resect procedure of the ipsilateral eye. The contralateral eye is only beneficial if the patient agrees and there is aberrant innervation with the MR fibers being transferred to the superior rectus, and you're able to see the ptosis getting corrected on attempted adduction. And of course, the FDT is free. So the lateral rectus should not be tight, because otherwise you're not going to get the effect anyway. You're going to start seeing bit of retractions happening, but nothing else. Any other questions, comments? Dr. Digvijay, our panel up front.
This is a very challenging situation.
As Dr. Yeah, Mike.
As already you've described that this is probably the most challenging form of strabismus to treat, because you only got practically one or two functioning muscles that are there, and you have to choose carefully and individualize each case.
So thank you. I think we'll go on to the next of the paralytic strabismus, which is the trochlear nerve palsy, and Dr. Aanchal will be talking on trochlear nerve palsy.
So coming after third nerve is the fourth nerve. The first case we have, can you have the slides please?
Yes.
The first case we have is a 28-year-old female. She presented with an upward deviation of the right eye with the left-sided head tilt, which was noted in childhood. On examination, we have a left-sided head tilt with a shortening of the mid-facial region of the left side,
Visual acuity is 6/6, anterior segment is normal. On 9-gaze examination, we can note in the primary rays there is a right eye hypertropia, which is
You can use the pointer if you want. Yeah, especially for that.
we have a right eye hypertropia, and it was measuring in the primary gaze to 20 prisms base out with R/L of 35 degrees. On right-sided head tilt, we can note that the hypertropia is worsening, but on the left-sided it is normal. On fundus examination, excyclotorsion can be noted in the right eye. So a diagnosis of right eye congenital superior oblique palsy was made, and accordingly an FDT for superior oblique was done. And we noted that the superior oblique tendon was not felt. So a combination of superior oblique tucking procedure along with an IO weakening procedure of recession with an anterior positioning was done. We obtained a good post-op correction, and as we can see in the primary and the down gaze, the patient had no complaint of diplopia. Second case is again a case of congenital superior oblique palsy. Important thing to note over here is again a left-sided head tilt and shortening of the mid-facial region of the left side. In the primary gaze, again a hypertropia can be seen, which is worsening on the lever version gazes. The value was measuring to 20 prisms base out with an R/L. Surgical plan was again similar, but there is a difference because in the superior oblique traction test, it was only mildly lax. So we have operated a single muscle over here, right eye inferior oblique weakening procedure was done. We obtained a good post-op correction, and there was no complaint of diplopia. Third case is post-traumatic. We have an adult patient, 24-year-old, with a history of trauma to the head 5 years back, which was followed by an upward deviation of the left eye, and it was associated with diplopia. On examination, there was a right-sided head tilt, not very evident in the picture. However, we can note that the face is symmetrical. Vision was normal, fundus showed left eye excyclotorsion, and it was measuring to R/L of 2 to 3 degrees. So diagnosis of left eye post-traumatic superior oblique palsy was made, and the surgical plan was again IO weakening with a good post-op correction. It is important to note the anatomy, especially for the post-traumatic cases, as the trochlear nerve starts in the inferior colliculus of the midbrain, and then it decussates posteriorly, so there's a very high chance of bilateral involvement. It is also important to differentiate between congenital and acquired cases, because acquired cases by default require a neuroimaging to know the cause. There are two very simple points to differentiate between them. If there is a combination of subjective torsion along with diplopia, then it is a sure shot sign of acquired superior oblique palsy. It is also important to know if the superior oblique palsy is bilateral in acquired cases, because it is often missed and it presents unilaterally, but after the correction we observe the other eye hypertropia. How to know if it's bilateral? There will be a positive bilateral head tilt test. Whenever the head will be tilted ipsilaterally, there will be hypertropia in the corresponding eye. Also, the hypertropia will worsen for the right side on left-sided gazes, and the left hypertropia will worsen on right-sided gazes. Management is simple. If the deviation is less than or about 10 prisms, we do conservative with Fresnel prisms. If the deviation is higher, the patient presents with diplopia, or the patient is taking an anomalous head posture, then we go for surgical correction. We broadly follow the general principles of NABS classification. The most commonly operated muscle is the inferior oblique weakening procedures, or the second option we have, depending on which gazes it involves the most, we can have a combination of inferior oblique weakening procedures along with the superior oblique strengthening procedure. Thank you.
Thank you, Dr. Aanchal. While you very nicely mentioned that management is simple, I would still I would tend to disagree to a small extent. Again, you're dealing with a patient who has binocularity in an adult patient, a patient who not only has possibly vertical and horizontal diplopia, but also torsional diplopia. So these become the challenges when you are managing, and again, because of the presence of a paralytic muscle which is managed by operating other muscles, you are bound to create some incompetence in some other gazes. So patients do tend to appreciate diplopia in other gazes. So it's important to discuss with the patient your potential problems that you can have post your surgery. So in any paralytic restrictive strabismus, your predominant aim is to have alignment in primary as well as down gaze, which is the most common functional areas of work. So if the patient can be made diplopia free in these areas, the patient is fairly comfortable and can be functionally good. Very often, especially if you do inferior oblique weakening procedures, you may have diplopia in up gaze, and we assume that that is not such a required gaze. But again, some patients do feel that there is diplopia in up gaze, which can be disabling for them. Yes.
So can you throw more light on SO tucking?
Okay.
Yeah.
Gunjan, you wanted to say something?
So I wanted to tell one thing, that sometimes hypertropia might not be so evident as was there in these cases, and sometimes facial asymmetry might also not be there in congenital cases who present as adults. They just present as they are starting having diplopia while they are climbing the stairs or while they are watching TV lying down, because it's in that case the superior oblique is acting. So vertical fusional vergence in these cases become important, because congenital cases usually have a very large vertical fusional vergence, which should be kept in mind and should be an important part of our examination also. And secondly, in adult patients, I have seen 3-4 cases who have presented with myasthenia and with the superior oblique palsy like picture in these cases. So that is also an important thing to be remembered, that when you are dealing with someone who is more than 40 years and suddenly has started having symptoms of superior oblique palsy, so myasthenia can be an important diagnosis in these cases also. See, the one of the patient, he was an orthopedic surgeon, so whenever he was operating, he was having diplopia in that gaze while operating. So he had a lot of problems, and initially the ACHR antibodies were also negative. So that was a bit confusing, but still we gave a trial of steroids and pyridostigmine in him, and he improved. He's fine.
That's a very interesting case. I mean, superior oblique palsies do have intermittent diplopia, because anyway they only have it in particular gazes. So sometimes it's difficult for the patient to tell us whether it's the intermittency in gaze or time. So yes, it would be a challenge to elicit the fact that the intermittency was with duration or with time in the same gaze. So that's a very interesting point, and we know myasthenia is the greatest mimicker. Of course, the dictum which I follow is that if I don't understand a squint, it is myasthenia unless again proved otherwise. But yeah, it can present with all kind of manifestations, from monocular elevation deficit to third nerve to anything. Usually ptosis is a frequent feature, but again it is not an essential feature for the diagnosis of myasthenia. So a very important point there regarding myasthenia. We've all been surprised by the way myasthenia has presented, and yes, talking about features about congenital, many of these patients get missed. They keep approaching an ophthalmologist, and their complaint is they are having difficulty in near work or reading or things like that, and we keep thinking it is convergence insufficiency, the most diagnosed disorder for which a lot of biceps get built up by doing pencil push-ups. But nobody actually realizes that because much of the near work is done in down gaze, these patients have difficulty because of inability after a period of time to maintain that fusion. Because looking in, as Dr. Gunjan pointed out, these patients have a very, very high vertical fusional range. The reason is that the brain has now learnt to overcome that challenge of vertical dissociation because of the superior oblique palsy, and the vertical fusion is maintaining that. Over time, because of increased near work, because of reduction in the fusional ability, they start breaking and they start manifesting intermittently, particularly in down gaze, and that is why these patients start coming to us in young adulthood, and we keep thinking if nobody actually checks their alignment in down gaze, we will tend to miss it, or even an extreme up gaze, or in the adducted position for that particular side. So a lot of them come. The head posture, if there is a head posture to start with in early childhood, that will result in that mid facial hypoplasia and that asymmetry of the face. Again, if there is not too much torsional effect because of the SO palsy, he may not have a significant head tilt, and therefore he may not have that midfacial hypoplasia during his development phase. So these are all signs which are suggestive, but of course nothing is hard and fast. You need to actually do a deep evaluation. Dr. Digvijay.
Familiarity of doing the Parkes 3-step, I think that is something we must all get familiar with, because in I think in most cases, if not all, it will give you the answer.
Absolutely. The Parkes 3-step test, particularly the step of the ipsilateral head tilt, will help us to identify a superior oblique palsy. It's more often than not positive, but yeah, in a very long-standing superior oblique palsy where there is a spread of comatants in other muscles, there may be an equivocal response to the head tilt test, and you're not always sure. Post-traumatic superior oblique palsy, always check the other eye. The risk of it being bilateral is very high, because usually the trauma is, or the injury is at the place where the superior the trochlear nerves are crossing, so it's likely that it is bilateral, though asymmetrical. So you operate one eye and then you find out subsequently that the other eye starts, inferior oblique starts overacting, and you realize you have a missed bilateral superior oblique palsy.
And also, I think, as you have told, myasthenia should always be kept as a differential diagnosis in a case of acquired SO palsy, especially isolated acquired SO palsy, and anticholinesterase receptor test can not always be positive. And in case if that is persistent for more than, like, if you for consecutive 2 or 3 examinations, you can go ahead with the surgery if you think the neostigmine test and the antibody test are negative.
And many a times all these congenital SOPs, they won't present in childhood. Rather, they would present in the early adolescence or later. It's only when the vertical fusional range is kind of, he started breaking. So what do you do in such, it's very difficult to identify whether it's acquired or congenital. Then you look for the old photographs of the patient. A very simple thing, you ask the parents to get the old photographs, childhood photographs, and there you can probably get the idea about the tilt, whether the tilt was there or not.
Thank you. I think we'll go on to the next paralytic strabismus, the abducent nerve palsy or the 6th nerve palsy or lateral rectus palsy. Dr. Swati Sharma here, she's going to present to us a case of the abducent nerve palsy.
Good morning, everyone. After oculomotor and trochlear nerve palsy, I'm Dr. Swati Sharma. I'll be presenting the case of abducent nerve palsy. So, a 25-year-old male presented to RPC OPD with the chief complaint of inward deviation of right eye for the past 2 years, associated with diplopia on right gaze. And patient alleged the history of trauma on the right side of the head 2 years back, following which the symptoms appeared. We did the ocular examination for the patient. BCVA in both the eyes was 6.6, and patient adopted a right side face turn to avoid diplopia. And on Hirschberg test, we could see that there was an esotropia of 15 to 20 degrees. On cover test, there was a right eye convergent squint. And on checking the extraocular movements, there was a right eye abduction deficit. On dilating the patient, we saw that there was no obvious disc edema in both the eyes. And we did a force duction test in the right eye, which was negative. We did a squint examination for the patient, and we could see that in the primary gaze there was a 15 to 20 degree of esotropia, and there was a right eye abduction deficit. All other extraocular movements were normal. We did the diplopia charting for the patient by asking the patient to wear red-green glasses and focusing on a streak of light, and we could see that the patient could experience diplopia in primary gaze, which increased on the right abduction. So we made the diagnosis of right eye 6th nerve palsy, and we planned right eye medial rectus recession of 5 mm and superior rectus transposition for the same. And in the post-op period, we could see that the eyes were aligned in primary gaze. So further continuing with the discussion of 6th nerve, it is important to know the anatomy of 6th nerve to which will help us in localizing the exact location of the lesion. So the 6th nerve nucleus is located in the lower pontine region, and the facial nerves fibers, they hook around the 6th nerve nucleus and they form a bulge which is known as facial colliculus. The 6th nerve nucleus, then the 6th nerve exits at the pontine medullary junction, and then it continues into the pontine cistern in the subarachnoid space. Then it travels up the clivus, goes on to the petrous part of the temporal bone, reaches the apex and travels in the Dolorous canal. And then it enters the cavernous sinus lateral to the internal carotid artery, further traveling into the superior orbital fissure and then innervating our lateral rectus muscle. While evaluating the case of abducent nerve, we have to identify and treat the cause. So if the cause is raised ICT, we can see on fundus examination there will be a papilledema. And if there is any vascular cause, if we are suspecting a vascular cause, we have to do a full hematological workup for the patient, CBC, ESR, LFT, RFT, and homocysteine levels. So based on the signs and symptoms which will be present in the patient, we can localize the exact anatomical location where the sixth nerve is damaged. If there's a horizontal gaze palsy, it means that the MLF is also injured, so the probable location would be nucleus. If there's a contralateral hemiparesis, it can be associated with Raymond syndrome, and if there's a ipsilateral seventh nerve palsy or multiple nerves are involved, then the lesion could be fascicle. If there is a disc edema or papilledema seen, it means the cause is raised ICT, which could be in the case of meningitis as well. So it would probably in the subarachnoid space. And if the patient has persistent otorrhea and patient has pain in the trigeminal nerve distribution and there's a diplopia, it means the sixth nerve is involved. Along with these symptoms, then it points towards a Greden-Egos syndrome. It means the anatomical location is the petrous ridge. If the multiple cranial nerves are involved, we all know that in the lateral part of the cavernous sinus, third, fourth, and first two division of the trigeminal nerve, they have a course along that. So probably the location would be cavernous sinus. If it is orbital apex, then it is rarely present, but it can be seen in the case of aspergillosis infection. So we don't order neuroimaging for all the patients. There are few indications in which neuroimaging is done. So if there is an associated disc edema in the fundus examination, then we order neuroimaging. If any neurological sign symptom deficit, as I pointed out earlier, like contralateral hemiparesis is present, or we see any other nerve involvement, we have to order neuroimaging. If the symptoms are increasing over the time, normally we have seen that over the period of 3 to 6 months, these cases spontaneously recover, but if they are not resolving or if they are worsening over the period of 3 to 6 months, then we have to order neuroimaging. And if the patient is young, which is less than 45 years of age, then also it becomes an indication. So how do we manage these patients? We have to do a force duction test. If duction is present or absent, if it is not present, we have to see the duction beyond the midline. If it is not present, then we do a FDT for MR, which is force duction test for MR. If it is free, then we plan for transposition plus minus MR recession. If it is not free, then we have to do active force generation test for LR. If it is weak, then we again go for transposition plus minus MR recession. If it is moderate, then we do recession and resection procedure. And if duction beyond the midline is present, then we also plan for recession and resection procedures. We can go for vertical rectus transposition. We can do a double muscle or single muscle, which could be superior or inferior rectus. If we are going for double muscle, we can do full tendon or partial tendon. And we can also go for additional procedure like MR recession, Foster suture, or Botox injections. If we are doing single muscle, superior or inferior rectus, then also MR recession or Foster sutures can be done, and supramaximal recession or resection procedures can be done. So this was a study done by our center, in which we compared various procedures, vertical rectus transposition procedures for LR palsy, and we found that the corrected ESO deviations were better in some procedures like partial tendon, vertical rectus transposition without with posterior augmentation, and partial tendon VRT with medial rectus recession. Thank you.
Thank you, Dr. Swati. Each of these paralytic strabismus, beside of course highlighting the individual management, we try to bring out something very specific. Like in the sixth nerve, we talked about the fact that it is a false localizing sign. Plus, of course, in every paralytic strabismus, it's very important to do all cranial nerve examination and possibly at least ask for symptoms, systemic symptoms of any neurological, that is sensory or motor deficit. Because in an adult patient, while a mononeuropathy may be related to an ischemic cause like diabetes, hypertension, hyperlipidemia, but the presence of even one more neurological symptom means that it is no more a mononeuropathy. In fact, the condition becomes localizing, or you are able to localize the site of the region involved, and you need to direct your imaging accordingly. A non-specific MRI or a CT often may not pick up a small lesion and may lull us into a feeling of confidence, which may not necessarily be true. So do a comprehensive examination. In any oculomotor palsy, there may be associated neurological symptoms or other cranial nerve involvement that helps to localize us, as we saw in the sixth nerve. That's true for all third and the fourth nerve, or even the fifth nerve. We can localize the site of lesion, advise directed imaging, and therefore plan whatever is required. So if there are multiple oculomotor nerves involved, either it's the cavernous sinus or the orbit, so you look for signs of orbital involvement. So you may have a small pseudo tumor presenting with multiple cranial nerve palsies with visual deficit, and you order an MRI brain. It does not focus on the orbit, and you miss it, and you still don't know where you are, and you are just non-specifically grouping in the dark. So identify all the involved nerves, all the neurological systems that may be involved. If present, try to localize, advise your imaging directed towards where you think that the site of lesion is.
Also,
Yes.
I feel that any palsy, should be investigated, especially acute palsies, unless these are congenital and you're sure about it. So all of them need a neuroimaging. You must first identify what the cause is and then accordingly first treat them. So meanwhile, you do not jump onto surgery immediately. You have to wait till at least 6 or 9 months or maybe a year for the spontaneous resolution of these palsies. So meanwhile, what can you give? You give conservative measures like prisms could be given, or you can just ask the patient to patch, and also botulinum toxin. So I think sixth nerve palsy is a very common and very easy, indication where you can give the botulinum toxin in the medial rectus muscle. Medial rectus is very close to limbus, easily accessible. So you just go, and with the help of a needle, you can just inject the Botox, and it gives a temporary relief to the patient. So that's it.
In fact, not only giving early rehabilitation, botulinum toxin will prevent the muscle from going into contracture, which may be helping in the long term. Although there are no studies that have shown that early interventions make long-term difference, but at least, if you're not giving botulinum toxin, at least advise the patient to patch the other eye, so that there is movement or attempted movement and abduction, and the medial rectus gets inhibited intermittently, so that it doesn't go into long-standing contracture. So in fact, patients have a tendency of occluding the deviating eye. It would be better, at least in known surroundings at home, for them to occlude the normal eye, so that they can at least attempt to abduct, and therefore have innervational inhibition of the medial rectus, which may prevent long-term contractures. Any comments from our experts?
Fundus
Yes.
evaluation should be an important part of sixth nerve palsy, and sometimes even idiopathic intracranial hypertension patients can just walk in with sixth nerve palsy with disc edema, and they might not have any MRI lesion also. So that has to be an important part of our examination always.
As Dr. Gunjan said, for sixth nerve, fundus evaluation is must. But I would say any patient who walks into your OPD, we are ophthalmologists after all. That is a basic thing we should always take back. Every patient should be, I don't think any physician is not going to measure blood pressure in an adult, even if he comes with abdominal pain. So it's important for us to look at, the gross things that a patient may suffer from. You may miss so many lesions of the retina or fundus, even if the patient has come for non-specific. So, but yeah, of course, in any paralytic strabismus, a fundus exam is a must. It's part of evaluating the second nerve. So any paralytic strabismus, complete cranial nerve palsy cranial nerve evaluation is must. So is a fundus evaluation. So great. I think if there are no more comments, we'll go on to restrictive strabismus. Again, another very challenging set of conditions, and we'll start off with Dr. Himani here, who's going to present on Duane syndrome and the management.
A very good morning to one and all present. I am Dr. Himani Thakur, and I'll be carrying on this learning fiesta forward with one of the most intriguing topics of strabismology, that is Duane retraction syndrome. So it is a congenital cranial disinnervation disorder, which is characterized by variable limitation of horizontal ductions depending upon the anomalous LR activity and how much the MR is supplying the LR. Due to the co-contraction, there might be globe retraction with or without shoots. So clinically, we classify DRS based on the deviation in primary position. So in this picture, we can see it is a case of left eye ortho DRS because in primary position, the eyes are absolutely aligned along with the characteristic features of globe retraction and limitation of duction in the left eye. So this is a case of left eye ESO-DRS based on the primary position deviation, and here is right eye exo-DRS, wherein the right eye is in exo-deviation in primary position. So the indications for surgery in DRS includes correction of primary position deviation, anomalous head postures, and unacceptable retractions or shoots. So here is the first case. This 22-year-old gentleman presented to us. If you focus on the left eye, we can see that he has limitation of duction in left eye, and on adduction he is having globe retraction. So he's a case of left eye ESO-DRS. When we did the FDT for AB duction, it was tight. The surgery that was planned was MR recession, left eye MR recession. And this was the pre-op, and this is how the post-op looked like. So we can see that the retraction has significantly improved with MR recession alone. But the thing to be noticed is that there is some limitation of adduction now in the operated eye also. Here is another child. We can see he presented with right face turn, and if you focus on the right eye, you can see that there is severe limitation of AB duction with retraction. So he's a case of right eye ESO-DRS with right face turn. So he was planned for right MR recession with superior rectus transposition, and on post-op he looked like this. So we can see with SRT his AB duction has improved as compared to what he looked like previously. So another female, you focus on the right eye. She is esotropia on primary position. On adduction, she is having globe retraction, significant limitation of AB duction, and along with shoots. So she's a case of right eye DRS with severe retractions and shoots. FDT for AB duction was mildly tight. We went ahead with right MR recession, and to tackle the retraction, we went ahead with Y split, LR recession with Y split. So this is how she looked in post-op. The retractions have significantly improved. So here is another 9-year-old who presented. She looks slightly ESO in primary position. We can see bilateral AB duction limitation, and on adduction she is having severe retraction with a V pattern in left bilateral eye overaction, but more in left eye. So left more than right eye overactions. So she's a case of bilateral DRS with left eye overaction. The FDT for AB duction in both eyes were mildly tight. She was planned for both eye MR recession with left IO recession 10 mm. So this is how she looked in post-op. The primary position deviation has been corrected. The retractions have significantly improved with correction of the pattern. So to summarize, when we are tackling ESO-DRS, a unilateral case with minimal co-contractions, a simple MR recession might suffice, but in cases of larger deviation, we might need to add on a superior rectus transposition or partial VRTs. In cases with unilateral DRS with severe, moderate to severe co-contractions, the MR recessions, we have to add LR recession with or without Y splits. And in cases of bilateral ESO-DRS, bilateral MR recession with or without superior rectus transpositions are the procedure of choice, and in cases of co-contractions, LR weakening procedures will also be required. So here is another female, a 23-year-old with right eye exodeviation in primary position, and we can see that she is having globe retraction on adduction with significant shoots. So she's a case of right exo-DRS with mild retraction with shoots. We went ahead with LR recession with Y split in the right eye, and you can see the retraction has significantly improved with the LR recession alone. Here is another patient with left exo-DRS with severe upshoot. So we can see that we cannot even see the cornea on adduction. LR periosteal fixation was planned for the patient, and on post-op the shoots have significantly improved. So to summarize, exo-DRS with normal activity in adduction, in absence of shoots, LR recession might suffice, but if overshoots are present, we need to combine it with a Y split. And in cases of absent LR activity, left LR periosteal fixation or supramaximal recessions might be required. So while tackling an ortho DRS, it is the question that we need to ask ourselves is whether we'll intervene or not. So here is the female ortho in primary position, right eye abduction limitation and mild retraction on adduction. So such a case presents to our OPD, the patient does not complain of anything significant, we can just leave the patient and observe her. So ortho DRS with no significant shoots or retraction, no intervention can be observed, and in cases of shoots, Y split can be done, and in cases of retraction, asymmetric MR and LR can be done in the affected eye. Thank you so much.
Thank you, Dr. Himani. Any comments? Yeah, please.
The amount of MR recession which has to be done in DRS again has to be kept in mind. It has not to extend beyond 4 mm, as in normal cases we can do up to 6, but in DRS we have to keep in mind it has not to be done beyond 4 or 4.5 because of the risk of synergistic divergence, again which has there has been a case report from our from RP center itself regarding the synergistic divergence in these cases. So comments from.
So absolutely, I mean, I would say that you need to do, so the dictum for MR recession is not an amount, it's on just your entering to recess MR to free the FDT. So do as much that will free the FDT and not more. The reason for, I mean, the other thing you need to actually look for when you're doing MR recessions for EZO-Duans is the amount of co-contraction or retraction. If that is present pre-operatively, you are going to land up with a synergistic divergence in if you just do the MR, because a weakened MR is going to now work against a nearly 1.5 or a double contracting lateral rectus. So the first case where we showed we had only done small amount of MR recession, the adduction deficit is essentially a synergistic divergence in the opposite gaze, and if the co-contraction is more the co-contraction, more effect of this co-contraction you are going to see. So if your lateral rectus is abnormally innervated for a larger extent, by seeing a larger amount of retraction on attempted adduction, you may even have a splits or a divergence in primary gaze itself. So in these conditions, if you have an EZO-Duans with significant retraction, you have to weaken the lateral rectus along with the medial rectus so that you overcome this risk. The downside is that your correction of the esotropia may not be as much, and maybe you will require a second stage of maybe weakening the other eye medial rectus, or else with a delayed time you may think in terms of a superior rectus transposition or a belly transfer, so that you are able to augment the primary gaze correction. So absolutely, you in an EZO-DS weaken the MR as little as possible, because it's actually already a weak muscle. It's looking EZO, it's looking as if there is the muscle is overacting, but actually the very concept of Duans is that the amount of innervation going to the medial rectus is less than normal. What do we call a muscle that is getting less than normal innervation? A peritic muscle. So really the MR is also having a problem. The main problem is because of the abnormal innervations to the lateral rectus, and that is showing all the clinical features of Duans, but the MR is also subnormal because it is subnormally innervated. So you weaken a slightly weak muscle, you are going to see adduction deficits, you may see actual divergence occurring even in primary gaze, as Dr. Gunjan points out. So any comments? So I think, yeah, well, very, very nice presented on Duans, all the various types of presentations we see, and as highlighted, if you don't think you can do better, don't do it. you must always discuss with the patient what you can provide. It's virtually impossible to provide abduction. It may slightly get improved, but really getting good abductions is not possible. So the patient should know, because post-operatively they're definitely going to complain. However much you may tell them pre-operatively, they expect the moon out of you. So they will always come back and say, but the abduction didn't improve. And then you have to retell them that we told you so. But then they'll always come back and say, but we thought that, you know, a little bit improvement will occur, that because you're operating. So these are the, you know, problems of, you know, operating advance. So I think we'll go on to the next talk. Again, another very interesting topic, which is Brown syndrome. Dr. Mrinalini here. She's going to run us through understanding managing Brown syndrome.
So carrying on the discussion, here we have an 18-year-old girl who presented to us with the chief complaints of inward deviation of the right eye, which was noticed by the parents since birth. And she had history of wearing glasses since 14 years of age. Trial of patching was also given. Her best corrected visual acuity with glasses in the right eye was 618, and in left eye it was 6.6, and there was no significant anisometropia. Coming on to the 9 gaze, what we can see in the primary gaze is that the child has a convergent squint in the right eye. Also, there you can see that there is a small hypotropia. On the straight up gaze, you can see that there is a significant limitation of elevation. On adduction, you can see that the hypotropia is increasing and there is a severe limitation of elevation. While on abduction, you can see there is a near normal elevation. So based on this, we made a diagnosis of right eye congenital Brown syndrome with a right convergent squint with strabismic amblyopia. She did not have a head posture because she was in ESO, and her sensory examination also showed right eye suppression with amblyopia, which is not normally seen in a case of Brown's. So looking at the CCT of the patient, what you can see here that what you can see here that this is the unaffected side, and here you're seeing the trochlea and the insertion of the SO tendon. You can see that the tendon is tapering on this side, but on this side you don't see the tapering. So on the affected side or the right, on the affected side or on the right side, there's a slight thickening that you notice in the SO, which corroborates with our diagnosis. Coming to the differentials, the important differentials are inferior oblique palsy, in which you see an A pattern, while in Brown's you see a Y pattern. In our case, the Y pattern was not that prominent because the patient had an ESO. The FTT was positive in our case, while negative in the case of inferior oblique palsy. Monoocular elevation deficit, you can differentiate by the elevation is limited both in adduction and abduction, while in Brown's it will be limited only in adduction. CFUM also will have restricted elevation in abduction, can have perverted convergence in upgaze, and can also have ptosis. So Brown's causes or etiology can be divided into congenital or acquired. Initially, when Harold Bailey Brown described it in 1950, he considered it to be short anterior tendon sheath, and he called it an SO tendon sheath syndrome. Now we consider that it could also be that the tendon is normal, but it's an inelastic tendon, or it could be a tendon trochlear complex abnormalities, or even people are considering that it could be a part of a CCDS. Acquired cases, causes, there are a myriad of causes, could be inflammatory causes with a systemic association like a rheumatoid arthritis, SLE, or associated sinusitis. Trauma is a very common cause. Then iatrogenic post-surgery, we see a lot of cases after sinus surgery or an SO tuck, we used to see scleral buckling or a glaucoma valve surgery. Coming on to the management, when do we operate a case of Brown's? So only and only if there is it is threatening binocularity, or if there is primary position hypotropia, or to correct the abnormal head posture or unacceptable downshoots. And you should be clear with the patient also what is your aim of surgery, clear with the patient also. So you correct the hypotropia in primary gaze, you reduce the downshifts or expand the binocular diplopia free fields. In mild to moderate cases and acquired cases, Sometimes there's no intervention needed. They say that congenital Browns also can sometimes improve spontaneously on its own. And exercises have been described. You can do elevation and reduction, and forced action has been tried. Steroids are the treatment of choice in case it is inflammatory. So the surgery, in our case, we made a diagnosis of right eye Browns, and there was a primary hypo in primary. So we did a SO tendon lengthening procedure with the chicken suture elongation, and since there was also esotropia, we did an MRI session of 4 mm. So this is the post-op of the patient. Here you can see in the primary position, the patient is aligned, and comparing with the pre-op, also you can see that the elevation and abduction has also improved slightly. Coming to other surgical managements, initially SO weakening procedures were described where you were completely disinserting the SO tendon. If you do it closer to the trochlea, the effect is more. If you do it closer to the insertion, the effect is less. But post-op, a lot of cases of SO palsies were seen and reported as high as 80%. So we have moved on to SO lengthening procedures. First described with a spacer, like a silicone band expander you can do, which was described by Dr. Kenneth Wright, which you can see here. To lengthen the tendon, you're placing a spacer. Then NAPS chicken suture lengthening, you're just doing a suture elongation, which was done in our case. You can do also a loop tenotomy, and split tendon lengthening is also done. Like you can, if you need a 5 mm or a 6 mm, 8 mm, you can elongate the tendon by that. SO tendon shave is also being described. If the tendon is thickened, you can just shave it along the length of the tendon. Thank you.
Thank you, Dr. Mrinalini, for covering Brown syndrome. Any comments or comments?
Audiences in LT7 also. So if you have any questions here in LT7.
So Rebecca is there in LT7. Dr. Rebecca is there. So
yes, sir.
We can hear her
so we
voice
have
and
your
we can't
audiences.
see her
So
though.
if you have any questions, the mic is connected, so you can ask your questions or your doubts
Yes.
over here.
So
No questions I hear, sir.
Nothing on Browns?
No, sir.
That's good. Good that Browns is so excellently cleared by Dr. Mrinalini. It's a tough subject and not so frequently seen, but again, we should be aware of its presence and more importantly when to intervene. It's very important if only it is vision threatening, if there is risk of amblyopia. If the patient is aligned in primary and adducted position and only there is limitation of elevation in adduction, maybe you can just follow up and let that patient be, because even post-operatively our aim is to not result in severe superior oblique weakening. Again, because of the importance of binocularity in down gaze, we would not mind some residual limitation of elevation and adduction, provided the eyes are aligned in primary and adducted position and in down gaze. But I would be loath to develop a superior oblique palsy. One of the reasons why we stopped doing free tenotomy tenectomies, particularly of the superior oblique, because it has been shown that almost 2/3 of these patients who underwent superior oblique tenotomy tenectomies will end up with superior oblique palsy in the long run. So I would say that mild Browns as a disease is far better than having a superior oblique palsy as a consequence of intervention because of the problems on down gaze. So we would that is why use or do a procedure that we can control and decide how much, and not let nature do its decision of how much weakening or strengthening there should be. So that is why we've kind of completely given up on free tenectomy tenotomies of the superior oblique and myectomies of the inferior oblique. Inferior oblique is a very, very useful mother. I mean, a muscle, I say that the inferior oblique is like our mother. You do whatever you want, you be as rude to her as possible, but she always loves you. So we make use of the inferior oblique, as we'll see in so many different procedures. It helps us tremendously. So it's very, very important to be very careful and decide what inferior oblique surgeries you're going to do. And superior oblique is like your teenage girlfriend. When we are in teenage, you touch her even, or you know, do even a slightly irritating thing, and then you've had it. You are in for trouble for, you know, many years. So that's what it is. So you can't just let her go. If you know, just dump her, then all your life you are going to face the wrath of a woman's scorn. So that's why superior oblique do not do free tenotomy tenectomies. You need to be very careful and controlled in your interventions. Just like recti, we don't just let it go like that. We do controlled recessions. So whatever muscle we are touching, we should know what we're doing and anticipate the effect that we're getting. It's not always 100%, but it's definitely more than you know, an unpredictable procedure. So we'll move on to the next talk on monocular elevation deficit. Dr. Gunjan, who's done a lot of work on that. So we'll have Dr. Gunjan presenting to us on monocular elevation deficit.
Thank you for the opportunity. So I'll be speaking on monocular elevation deficit. So monocular elevation deficit is the limitation of elevation of the affected eye with normal ductions in all other cases. The elevation will be limited in both abduction as well as adduction, and there is a frequent association of hypotropia, ptosis and pseudotosis. It has been classified into 3 types depending upon what is the post-duction test for inferior rectus. In type 1, it is caused because of the tight inferior rectus, and in type 2, it is caused because of the superior rectus palsy, and type 3 is because of the supranuclear causes. My presentation is mainly limited to type 1 and type 2 monocular elevation deficit, and I'll be discussing a few subset of cases of each of the type. So talking about the first case, he was a 15-year-old male who presented with congenital severe ptosis, and it was a complex type because patient had limitation of movement in the upgaze. He had hypotropia, and there was Marcus gun jaw winking phenomena also which was present. So we can make out from the pre-op picture, as you can all see, that there was a very large hypotropia of around 35 prism diopters, and along with that there was also an elevation deficit. A component of pseudotosis was also there. On post-duction test, the inferior rectus was found to be tight, and hence I planned inferior rectus recession of 5 mm. And we can see in the post-op picture that there was slight improvement in the ptosis also, which was noted as compared to the previous picture as we have seen here. Now the second case in this subset is of a 20-year-old male who had persistent diplopia and limitation of movements in upgaze after a road traffic accident which took place around 2 months back. On NCCT, inferior rectus was not found to be entrapped. There was a very small fracture which was less than 2 mm, and there was only soft tissue entrapment. Keeping in mind all these factors, I performed a post-duction test for inferior rectus which was found to be tight. There was a hypotropia of 25 prism diopters, and inferior rectus recession of 5 mm was planned, and we can see in the post-op there was an improvement in the elevation as compared to the pre-op picture. So again, she was a 25-year-old female who presented with limitation of movements in the upgaze, and there was a tight inferior rectus, and we can see that the movements were limited both in abduction as well as in adduction. And inferior rectus was found to be tight. A recession was performed for inferior rectus of 5 mm, and then we can see the post-op picture that there was an improvement in the elevation. Coming to the second subset of the cases, so this patient was a 20-year-old female who presented again with complaints of congenital severe ptosis with Marcus gun jaw winking phenomena, and there was a limitation of movement in the upgaze. Moreover, the patient also had a very large horizontal deviation of 50 prism diopters, and the vertical deviation was also large. It was around 30 prism diopters. Patient was not ready for the other eye surgery, and I had to plan modified NAPS procedure for her, that is recession of the lateral rectus and medial rectus resection along with the superior transposition. This was the post-op picture, and there has been an improvement in the vertical deviation, though there is some residual horizontal deviation still present, and the Bell's, and the good thing is that the Bell's has improved, so I can plan her for the ptosis surgery now after 3 months. Now case of type, again this is a case of type 2 MED where the inferior rectus was found to be free. The patient has esotropia. Along with that, there is limitation of -2 in the right eye. The patient was only planned because the horizontal deviation was less than 30 prism diopters. The patient was only planned for a single muscle resection and transposition. and recession of the muscle was not planned intentionally. I'll be coming to it. Now, again, this was a similar case of a 14-year-old who presented with congenital severe ptosis and an elevation deficit of -2. I planned for modified naps, and this was the post-op picture showing the improvement in the pseudotosis. So, how do we plan? It all depends upon the force reduction test. If it is tight, go for inferior rectus recession. If it is free, perform NAPS procedure. If there is a horizontal deviation also present, go for a modified NAPS. But is it so simple? No, not at all the times, because of the large horizontal and vertical deviations which are associated with this entity. Correction has to be planned, because that's the main reason why the patient has approached to you. And many a times patients are not going to agree for the contralateral eye surgery. This is the table showing the effectiveness of various surgical procedures as has been described in various studies. According to my observation, in type 1 MED, one should be careful with inferior rectus recession. It cannot correct more than 20 prism diopters at the most, and excessive inferior rectus recession, that is more than 5 mm, can lead to lid retraction. In patients with positive FDT and large hypotropia, inferior rectus recession thus may not suffice, and you need to perform NAPS or augmented NAPS after an interval of 3 months to prevent the anterior segment ischemia. Modified Nishidas can again be a helpful procedure to prevent ASI, but the long-term results of the same has not been known. In type 2 MED patients where the inferior rectus is free, transposition of the recessed muscle weakens the effect of NAPS and hence should be avoided. It was also observed in a similar observational study done at RP Center and which has been published, that for horizontal deviations less than 30 prism diopters, resection of single muscle with transposition should be planned, and for horizontal deviations more than 30, patients should be counseled for the other eye surgery. For residual vertical deviations, one can plan contralateral SR recession and IOTAP. Thank you. Thank you to my teachers for whatever I know little in squint.
Thank you, Dr. Kunjan, for wonderfully talking about and presenting monocular elevation deficit. Any comments? Whenever you're doing inferior rectus recessions, please remember, if you're going beyond 4.5 or 5 millimeters, you need to do a nasal transposition along with the recession. Otherwise, you are going to create an A pattern in down gaze, because not only does the inferior rectus cause a depression or the eye to roll down, but also when the eye is going down, the inferior recti pull the eye inwards, which is a bit of convergence that is required when you're looking near, which is what is expected when you're in down gaze. So most of the time in down gaze, you're looking at nearer objects, and therefore the inferior recti there are very, very important adductors in down gaze. If you weaken the inferior rectus for the vertical correction, you may have a divergence in down gaze or an A pattern. So a patient who is preoperatively fusing will start facing difficulty in down gaze. So the nasal shift is necessary to maintain the direction of pull and therefore maintain the adduction force in down gaze. So that's important when you are planning for anything, a large inferior rectus recession. Yeah, Dr. Digvijay. Yeah, so as Dr. Digvijay points out, that for any paralytic or restrictive strabismus, you need to do a forced duction test. Again, it's very, very important to be able to diagnose. It's part of workup. You have limitation of movement, you need to know why there is limitation of movement. Is it a restrictive pathology or is it a paralytic pathology? So if the FDT is free, you know there is a paresis or paralytic component to it. If there is a tight FDT, you know there is a restrictive component that may be subsequent to a paresis or maybe the primary pathology as in Duanza-Brown. So that is very, very important. For recti, remember to lift the globe and rotate the globe. Lifting is important, otherwise you will have a false negative. If the globe in your attempt to roll is pushed back, the muscles are made lax because the globe is retropulsed, and therefore you will have a false negative FDT. There is a restrictive element to it, but it is overcome because you have pushed the globe back and make the rectile lax. Similarly, when you're doing FDT for superior oblique or inferior oblique, which is very, very rare, you have to lift, you have to press the globe down, push it back, and then do your FDT, because again you have to put your superior oblique on stretch. If you lift it, the superior oblique, because it reflects back, is going to become lax, and again you're going to get a falsely negative force duction test. So these are important small necessary tips in workup and again for decision making. So I think we'll go on to now probably the most difficult to understand, what to say, manage topic, which is nystagmus, and Dr. Asha here is going to run us through a bit about nystagmus.
Very good afternoon, everyone. I'm Dr. Asha Samdani. At this outset, first of all, I would like to thank Dr. Rohit, Dr. Rebecca, and Dr. Swati, and Dr. Rama for giving me this opportunity. So I'll try to simplify nystagmus as much as I can. So just for keeping first year residents as well in so the nystagmus is basically a slow phase which gets you the movement of the eye away from the visual target, and then there is a corrective brainstem corrective action which gets it back to the target. So this is CMAS classification of nystagmus. In this we are going to discuss INS and FMNS today. So this is infantile nystagmus syndrome. As you can see, this is infantile in onset. It's bilateral and conjugate. This conjugate is important. We will come to this later. And there are null and neutral zones present. So because there is a null and neutral zone, the patient has, in this picture you can see that there is a face turn towards right because he has a null in levo version. That means the intensity of nystagmus is reduced in the levo version. So this is the same case. He's a 6-year-old male patient. As we can see, there is a right face turn, and he has definitely the complaints of nystagmus since birth. On examination here, we can see that the binocular vision is better. Sorry, the binocular vision and uniocular vision are both equal, and the preferred gaze vision is better than the primary gaze vision. So this suggests that it is a manifest nystagmus and it's a gaze null. We'll come to this again. So here he has a 30 degrees of right face turn, there is no squint, and the stereopsis is also better in the preferred gaze than the primary gaze. So this is, the patient is having a right face turn here, and now you occlude the one eye, but there is no change in the face turn. That suggests that it's a gaze null. And this is the intensity of the nystagmus over here. And once you, in the left gaze, there is an increase in the intensity of the nystagmus. So this is a case of infantile nystagmus syndrome with a null in 30 degrees of levo version. So what's our surgical plan? It's an augmented Anderson procedure. In this we do a right eye MR recession of 9 mm, left eye LR recession of 12 mm. This is the post-operative video of the same patient. In this we can see that there is essentially no face turn now. So coming to the summary of this case, so this is a case of eccentric gaze null with a head posture in the opposite direction. So in this case, the important thing is we'll have to rule out periodic alternate nystagmus and also fusion maldevelopment nystagmus. So periodic alternate nystagmus, it's important to rule out because sometimes there can be alternating head turns, like this is a right face turn. Patient can also present with left face turn. In that case, you may have to do bilateral augmented Anderson procedure. Now this is the case of fusion maldevelopment syndrome. Manifest latent nystagmus. So this is also again infantile in onset. This is also bilateral on conjugate. Here the thing we have to notice in the V and G, here we can see that the slow phase is decelerating, whereas in the manifest nystagmus last time it was an accelerating slow phase. So here he's an again 6-year-old male patient. The nystagmus, he has also a deviation of vision. There is again a right face turn since birth. So coming to the examination, here we can see this is the binocular vision is definitely better than the uniocular vision, and uniocularly also the right is better. So the right is dominant, because of which he is keeping right in adduction, and also he is maintaining a right face turn. So it is a 30 degrees of right face turn, and he is having a null in adduction. We'll come to this in the next slide. He also has a small squint of LCS of almost 5 to 10 degrees. So here he is maintaining a right face turn. Now you occlude the fixating eye. There is an increase in the intensity of nystagmus. He has changed the face turn towards the other side. Now he is keeping the other side in the adduction. So this is a case of adduction null. Yeah. So the diagnosis is left convergent squint with MLM with adduction null. So the surgical plan here would be to correct the squint. We are going to operate on the dominant eye, MR recession of 4 mm in the right eye, and for the adduction null, we are going to do both eye posterior fixation 14 mm from the limbus. So this is the post-operative video. This is the post-operative video of the patient. Now we can see that the null has been shifted to the primary position, and there is a no face turn. So summarizing this case, this is a case of adduction null, and we have done a bilateral MR recession or Fadden. So when the eccentric null is with eccentric null in adduction, if the case is of esotropia, then it's a clear-cut thing. We can do the MR recession of the dominant eye to correct the squint. But if the case is an exotropia, maybe we'll have to do an MR recession of the dominant eye and squint corrective surgery in the other eye. So the differentiating features between manifest nystagmus and manifest latent nystagmus. So this is manifest nystagmus is mostly pendular and jerking, and as we have seen that there is no change in the abduction, whereas there is a change in abduction because the fixating eye is generally in adduction, and increasing velocity, accelerating slow phase, and he's a decelerating slow phase. There is no change in the unilateral occlusion. Basically, there is no change in the head turn, whereas it increases on the unilateral abduction. Even the intensity of the nystagmus increases. Most of the times, it's associated with infantile esotropia, the manifest latent one. Binocular is same as uniocular in manifest, whereas binocular is better than monocular. So this is a small variation. So this is spasmus nutans. Spasmus nutans. So here we can see that it generally appears around 4 to 18 months of age, but it disappears by 3 years of age. Here, as we can see, last two nystagmus what we have discussed are conjugate and bilateral. Here it is a disconjugate nystagmus. You can see that the intensity of nystagmus is different in both the eyes here, and it's asymmetric. It can be multiplanar. It's not like a horizontal jerk nystagmus. It is dissociated. It can also become monocular sometimes, and it increases with the convergence. Neuroimaging is important in this patient because it can have some chiasmal lesion. So it's a triad of binocular pendular nystagmus, head nodding, and head posture or torticollis. So pan, we were discussing this previously, so he can have right face turn and also left face turn, for which we need to observe at least for 3 to 4 minutes, and because the management is different in this, bilateral augmented Anderson may be performed. So management can be either non-surgical, surgical, and also counseling. I'm not going to stress much on the management part. We can have that in discussion. So essentially the principle is that we'll have to shift the null to the primary position from the head turn. This is to increase the foveation time, and also if there is any associated squint, you have to correct that as well. There are so many surgeries, Kestenbaums, modified Parks, Andersons, and depending on the degree of the face turn, we'll have to modify and it can be increased by 40% or 60%. So augmented Anderson is nothing but MR recession of 9 and LR recession of 12. Fadden is considered in the cases of adduction null. So this is a pre and post of augmented Anderson, adduction null, and this is the chin down position in which we have done bilateral SR recession. We can also do it for the obliques as well. Yeah, so thank you for giving me this opportunity, and it's open for any questions.
Thank you, Dr. Asha. Very nicely took us through different presentations of nystagmus. Any questions while before we go on to the next presentation?
No questions in nystagmus.
That's something, unfortunately, true. Nystagmus can be challenging after long hours of discussion on strabismus, another challenging topic. So, but essentially it's important to differentiate. In strabismus, esotropias you need to look for associations, among them inferior oblique overactions, DVDs and nystagmus. So esotropias are commonly seen in them. We'll go on to the VAST session, and as we are a little behind time, I think we'll use what is called the cafeteria approach. So we'll start with something. We'll start with the salads, and then you can pick and choose. You can tell me what main course you want. So we'll try and run through recti. We've discussed various disorders. We've talked about recessions. Like I mentioned, we almost always do graded recessions, various modifications to graded recessions as weakening procedure. Farden was introduced by Dr. Asha for in nystagmus. It is also for managing whenever you have say even in shoots, people have described Farden, particularly of the lateral rectus. If there is a high AC by ratio, although bifocals is the treatment of choice, again some people have described that. So these are various weakening procedures that exist. Remember, there are always limits to recession that you may do. There are upper and lower limits. Less than a normal amount is not going to give you enough effect, and more than what is prescribed will result in the muscle going beyond the arc of contact, resulting in limitation of movement and significant weakness, and turning a comitant squint into an incomitant squint. So we'll just start with a video on recession. We can close the slides if possible, or at least reduce them. So I use the fornix incision. This is the opening made in the conjunctiva and the tenons, and you have passed the Jemison's hook and followed that up with the Green's hook so that it doesn't slip out when you bring the muscle out of the opening that you have made. So it is prolapsed out. You identify the superior pole and you make an opening there. The lens hook is passed through that, and you need to confirm that you have the complete muscle and you not split it. So this is identifying the superior pole, and then subsequently you dissect it to whatever you are comfortable with. Different people use different amount of dissections. So you dissect it enough so that you are able to pass adequate sutures. For the lateral rectus, always remember the inferior oblique is about 10 to 12 millimeters posteriorly. So dissecting inferior to the muscle, you do not want to risk damaging the inferior oblique. So if you're using a single double-armed suture 6/0 vicryl, you can have a single knot in the center so that you can prevent central sag, and then you tie 2 or 3 passes through both sides. You need to make sure that you have all the fibers in so that you do not have a slipped muscle in the post-op period. When you are measuring, hold it from away from where you are going to make your mark, because you don't want distortion of that point, and identify the mark, make it clear, and then pass your needle through it. Remember to be very careful in this step. You have an underlying normal retina and you don't want to create a perforation which can cause a detachment in the long run. So it's very important to identify your marks and your landmarks carefully when you're measuring and when you're passing your suture. So this is recession. We can tying suture, make sure that there is no tissue that is there at the time when you're tightening the sutures, because that can, again, when it retracts, it can cause changes in the outcome. So a recession procedure. We go on to strengthening procedures, graded resections and plications, 2 commonly done procedures on the recti. Tucking, double breasting, not really used or termed for recti. You usually use it for the superior oblique, so you can do a superior oblique tuck or a double breasting. Advancements are done when you want to have a strengthening procedure on a previously weakened muscle. So a recessed muscle can be advanced to the original position so that it can, so that's a strengthening procedure. We usually do not advance it anterior to the original insertion, because it then tends to start showing through the conjunctiva and a thick fleshy mass appears which is not a preferred thing. Again, you have maximum minimum limits of resection. Important to have a limit of resection because beyond a particular limit you have myofibrils there. So when you cut more, you are also slightly weakening it, so your outcomes or effect starts getting lesser and lesser. So we'll run through a video of resection. The procedure of identifying and isolating the muscle remains the same. Conjunctival opening, fornix opening, reach the bare sclera, pass your Jemisin's hook, sliding over the sclera, pass the Green's hook, prolapse the muscle out from your opening, identify the superior pole, make sure that you have the whole muscle, make an opening in the superior pole, pass your lens hook, identify that you have all the muscle fibers, you do not have a split muscle, and then do your remaining procedure. So the steps of isolating the recti still remain the same. You've made sure that you have dissected beyond the point from where you are going to pass your sutures in resection. So again, you make your mark, make sure that there's not extensive rolling of the rectus muscle from your muscle hook, because that will increase the amount of resection you're doing. So you need to be very careful. In resections, we usually use 2 double arm sutures. So in this case, you can see the open end of the suture, we've passed an RD needle, and so we've passed 2 double armed sutures, one superior, one inferior. You can do a small clamp of the muscle to clamp the vessels, a small cautery of superficial vessels. You cut it, you remove this stump. It's important again when you're passing sutures not to pass them through the overlying stump of the muscle, but deep through the sclera, so that there is a good strong bite and it doesn't cut through or slip later on, reducing your effect or resulting in a slip muscle. So pass your sutures through the underlying sclera. So resections, as they are tightening procedures, we would prefer to have 2 separate knots just in case one opens up. So 2 double armed sutures we started off with, and again that's the resection we've done. Just showing you plication, just as an ease of process, we've moved to plications now, reduced bleeding, swelling, but essentially no major difference in long-term outcomes in resection and plication, and I don't actually have modified the amount. So whatever I was deciding in the amount of resection, I have done the same as far as plication is concerned. So again, conjunctiva, sclera, make sure that you've reached bare sclera when you're passing your hooks. Otherwise, you'll have a lot of tissue and your surgical plane may not be clear. So again, this is called the pole test. You make the tip reach the edge of the limbus to make sure that you have the whole muscle. If the muscle is not completely slipped, you're not going to be able to touch the pole. So again, the process of identification and making sure that your muscle is complete, identifying the superior pole of the rectus, doing your dissections, and then again measuring where you're passing. So again, for still these are the steps are the same. That was for resection. Now instead of clamping, we've passed a suture. So I will be using 2 single armed sutures for plication. Do your regular passage through the muscle like you do for any resection, 2 or 3 passes to have the entire muscle in, 1 superior and 1 inferior. So you have these passages through the thick of the muscle so that you don't leave fibers that can cause a release or loosening up of the effect over time. So this is the first suture through the muscle. Now you go and identify the part just anterior to the insertion. So this pass your sutures just anterior to the insertion, not too far anterior because you don't want the effect to be different from what your resection plan is. So pass your suture through the both the sutures are passed just anterior to the insertion, deep through the sclera. The sclera is usually thick there. The next pass is back through the sclera, through the muscle, I'm sorry. So you have a muscle, sclera and back through the muscle again. So now you have 2 loops for the superior part and 2 loops for the inferior part, just like we had planned in resection. So you pull it anteriorly, usually the muscle will roll underneath the part, and you can see there is no significant clumping. The muscle has gone underneath the advanced part, and then you tie it. So again, you have 2 separate sutures with 2 proper passes through the sclera and muscle. So this is muscle, sclera, muscle attachments. increasing the strength and reducing the risk of the muscle loosening up over time. So this is how it appears, and you close the conjunctiva like you normally would. Like I said, we've moved to fornix now, but essentially the approach, whether it's limbal or fornix, remains the same for the muscle. Shiftings are described for pattern strabismus, so you move the medial rectus towards the apex and the lateral rectus away, and this is how it would appear. So the recessed part, which was downshifted, is here. So you measure about 5 millimeters inferior to or superior if it's an upshift to where your original plan was, and you pass your lower suture through that and the upper suture slightly midway or slightly towards it, because you can never get a 10 mm spread after you've done your you've disinserted the muscle. Similarly, if you are resecting, the resected sutures are going to be passed in clear sclera area about 5 millimeters above the original insertion. So that's how you're going to do your shifting procedures. As I mentioned, limbal and fornix, there's not much of a difference, so we could go ahead with either. These are broad nomograms. What we follow: recessions are stronger than resections, response of the medial rectus is stronger than the lateral rectus, and every muscle, of course, it varies. There is a range. Every muscle responses on different hands are different. So just you need to do a few surgeries to be able to gauge how much your effect is coming and adjust accordingly. Again, these are established nomograms. When you're starting off surgery, you follow them. They're more or less successful in all hands, but yes, slight difference happens in the way you measure, in the way you pass your suture, the amount of dissection you're doing. So these make that impact on the range of effect that is described, and therefore just follow a procedure. Just always be consistent in what you're doing. Evaluate what your results you're getting, and slight modifications will be required. We'll go on to obliques. Important to understand the anatomy. You can see this is the superior oblique, a beautiful fan-shaped insertion posterior to the superior rectus, slightly temporal also, or bang underneath the superior rectus. This is the inferior oblique coming and inserting slightly underneath, about 10 millimeters posteriorly and about 2 millimeters underneath or inside the inferior margin of the lateral rectus. This is important because that's how you're going to identify, isolate the muscle and do your planning surgery. Again, like I said, we always do graded recession or graded weakening procedures on the inferior oblique, and because of that we have a whole choice of procedures we can do. The inferior oblique can, right from being a weaker muscle, from still retaining its original function of excyclotorsion, elevation and abduction, to a complete reverse of its action, a slight weakened encyclotorsion or even a depressor muscle. So you can use the inferior oblique, like I said, to do anything you want. A lot of indications we've discussed over a lot of conditions that we've talked about. These are the various procedures that have been described. Again, there are a lot more. I'm just telling you what I commonly do based on the impact or effect it comes. So these are graded weakening procedures. The Finks recession, which is theoretically about an 8 millimeter recession originally from where it was here. So a 6 and 6 from the lateral rectus, 6 millimeters towards the inferior side, and then 6 millimeter posteriorly towards perpendicular to the cornea or the limbus. This is the Finks point, and your anterior suture passes here. This is the Parkes recession, where you're doing 2 millimeters towards the medial rectus, towards the lateral rectus, and 3 millimeters posterior. So this is the Parkes point and the Parkes-Scheis recession, which essentially gives us about a 10 millimeter weakening. You have the Elliott-Nanking, which actually made the inferior rectus into a depressor. So the inferior rectus actually starts acting like a weak depressor instead of an elevator that it actually is. To overcome or to prevent the anti-elevation and to reduce its effect, the posterior suture can be passed or passed right adjacent to the inferior rectus, so that you do not have these J-shaped problems of anti-elevation, which the Elliott and Nanking, we use sometimes this anti-elevation or a weakened anti-elevation effect, like say in a superior oblique palsy with hypertropia. So you are actually using that vertical correction in this condition. Again, this is responsible for the diplopia possibly present in upgaze, but helps us to correct the primary gaze hypertropia. And of course, anteronasal transposition described by Stager, that actually completely changes the action of the superior oblique, and it starts now becoming an encyclotortor or a weak encyclotortor instead of the excyclotorsion it was doing earlier. So I'm just showing you how we identify and disinsert the inferior oblique, conjunctiva, inferior temporal fornix, the The tenons, you hook the lateral rectus so that now when you pass your hook, your lens hook, this is the fleshy inferior oblique you can see. So under visibility, you press the sclera, you go posteriorly, and you can start seeing that white posterior intermuscular septum, which is showing that your muscle is complete in the hook. You prolapse it out of the conjunctiva, and again you can see your hooks through here, showing your muscle is complete. You can even lift it up and make sure that you are seeing the posterior intermuscular septum. You open this, again you can see the sclera right through, identifying that your muscle is complete. Make sure of these before you start your dissection, because a cut muscle will then start bleeding. So you've isolated, separated it from the lateral rectus, and now disinserted it. You can comfortably let the inferior oblique go. It's not going to go anywhere. Now, instead of struggling to pass sutures posteriorly, we've held on to the muscle. The assistant can now hold the muscle fully spread out. You can comfortably pass sutures through the cut end of the inferior oblique, so that you have the procedure all under visibility. So cutting the inferior oblique and passage of sutures all under visibility, and while hooking it can be a bit of an initial struggle, but subsequently once you've disinserted the inferior oblique, the process becomes very simple of passage of sutures. So this is how we are going to hook, disinsert the inferior oblique, and pass sutures. So now we are ready to, after passage of sutures, we are kind of ready to do whatever we feel like we want to do with the muscle. So however we want it to help us in our future correction of deviation, we can use. So this is hooking and disinsertion. I'm just showing you measurement of the phinx and the Parkes point. So this is the phinx point. You have the lateral rectus and the inferior rectus. From the inferior margin of the lateral rectus, you've taken one along towards 6 millimeters and 6 millimeters perpendicular here in this direction. So this is the phinx point, which is going to give us, if this is being used, about an 8 millimeter recession. So I'm in the same stage, I'm going to show you the Parkes, which is the 10 mm recession. So here you can see that you have a 3 millimeter posterior to the lateral margin of the inferior rectus, 3 millimeters posteriorly, and then 2 millimeters laterally. So you take another mark 2 millimeters laterally or towards the lateral rectus. So this is your point here. So this is the Parkes and this is the phinx. Not only does the Parkes give you a little more recession, it also brings the muscle about 1 millimeter or so anteriorly. So again, your action of the inferior oblique, because of its retroequatorial insertion, which is elevation and abduction, gets further weakened. So this is the advantage. So like I said, that's how we are moving graded wise. Phinx gives you about an 8 millimeter recession. Parkes gives you about a 10 millimeter recession. If you want a further weakening, you can do a modified iliac nanking. And if you want actually to have a very severe weakening, but be willing to compromise on a little bit of incompetence post-operatively, you can do an iliac nanking. And of course, if you have a superior oblique palsy, you would do a nasal transposition to correct for the cyclotorsion. So I'm just going to show you Parkes, how we are going to pass sutures here. So again, the same way to measure 3 mm and 2 mm laterally, and we pass the anterior suture through this. So this is the point where we're going to pass the anterior suture, and about 5 millimeters or so posteriorly, we're going to pass the posterior suture, so that the muscle is inserted almost in the original direction as it was, but nicely recessed and slightly anterior positioned. So this is how so the posterior suture is here, about 5 millimeters posterior converging together, so that you don't have a stretch on the final suture knot that you're going to tie. So this is how, so this is the inferior oblique, past your suture and tie it and close it. So this is just showing you the differentiation between iliac nanking and the modified iliac nanking that we prefer, and again it's role in different positions. Just again showing you passage of suture, how you do the modified iliac nanking. Very severe, fairly severe weakening procedure, but the muscle still remains in a comitant state. You're not having too much anti-elevation effect, you are able to get a good weakening effect of the inferior oblique without causing a significant limitation. So again, the first suture adjacent to the lateral margin or the insertion of the inferior rectus, and the second suture slightly posteriorly converging towards the original suture, so that you have about a 5 or 7 millimeter spread at the insertion point. So this is how it comes up, and you can identify and separate, you can see it separately from the inferior rectus. I'll just go on to quickly show the anterior nasal transposition. So this is all the inferior oblique has been isolated. You need to do a little more dissection of the inferior oblique when you're doing nasal transposition, because you want the muscle to comfortably rotate nasally. So this is the inferior oblique you're dissecting. The inferior rectus has been hooked. It has to be prolapsed again so that you can dissect and clean the nasal part. After doing that, you cut out the attachments between the inferior rectus and the inferior oblique, again so that it can be comfortably mobilized. There are no attachments. Now we move on to the nasal side. 2 millimeters nasal to the nasal margin and 2 millimeters posteriorly, as described by Stager. The anterior, which was originally the posterior suture, now becomes anterior, is passed through this point here that we marked. I'm sorry for the slight rotation that we have, the non-centering. And then the second suture is again passed a couple of millimeters or so posterior to that. You can see the inferior rectus there and the inferior oblique coming over that and getting inserted onto the inferior nasal compartment of the globe, so that it starts acting like a slight incyclotorter rather than the excyclotorsion. And this is the significant change in excyclotorsion. We saw it to change on a mean of about 7 degrees. So a 7-degree change in the cyclotorsion is there. We are almost running out of time, so I'll just quickly run through just the last one procedure we'll talk about is the superior oblique weakening procedures. We talked about the indications in a torsional Kastenbaum, a Brown's, and an A pattern. You can see the A pattern here. Whenever you have 9 gazes, start with the center, primary gaze, exotropia, you can see up and down, you can see an A pattern, convergence up, divergence down, corresponding superior oblique overaction seen on the horizontal gazes. You have a whole lot of superior oblique weakening procedures that were discussed. I'll just quickly show you a run through the posterior tenectomy of the superior oblique. We always prefer the temporal fornix approach to handle the superior oblique. It reduces the risk of post-op fibrosis that can occur on the nasal side. So this is essentially showing you what we're going to do. This is the superior oblique. These are the posterior fibers. Beautiful 10 mm fan of the superior oblique exists, and if we can harness it and use it, that's what. So the anterior fibers are responsible for torsion because they're pulling more in the horizontal plane, and the posterior fibers are responsible for the abduction. They pull inwards, this rotates out, as well as the depression movement. So as it pulls, it causes the muscle to go down, and that's what we are trying to weaken with the posterior tenectomy. So this is the posterior tenectomy of the superior oblique. So again, a fornix for obliques, it's even better to do a fornix, superior temporal fornix incision, conjunctiva, circumcorneal, radial for the tenons. Hook the superior rectus. Once you have hooked the superior rectus and put the lens hook, you can actually make out, it's not so clear here, but over time you'll start making out, these are the fibers of the superior oblique. You hook them directed posteriorly, but when you're prolapsing them, you rotate it slightly so that you do not damage the vortex vein when you're prolapsing out the superior oblique. Usually you're able to get it complete, but otherwise if you are in doubt, you may need to re-explore there and confirm that you have the entire superior oblique, because it's the posterior fibers that are the most important. You can do a tissue retractor to confirm, and if you can find out, just make sure that you eliminate those. But whatever you do, always identify the vortex before you change. Here you can see that the fibers actually change their shape. So these are more horizontal, they are more obliquely situated. So earlier we used to measure 2 millimeters. I don't often do that anymore. I just identify the turn and we just separate them. So you separate these anterior fibers. They are very thin, they look very delicate and gentle. So you need to be a little careful. You don't want to mechanically remove the anterior fibers also. Once you've hooked it, you cut the posterior fibers, you remove them completely, and you have the anterior fibers remaining there. So that's how a posterior tenectomy, you can identify the vortex veins and all also, and the clear sclera that you can see underneath. So it's very important to identify that. You can see the correction of A pattern in this case. So you can see the A pattern has been corrected. Similarly, the preoperative superior oblique overaction in this case is corrected here. So bilaterally posterior tenectomy of the superior oblique. So I think we'll stop there. Anything else we need to discuss, we'll discuss. We'll go on to the very interesting discussions that we hope to have now onwards on neuro-ophthalmology. And any questions while we're moving on to the next stage? I will request our chairperson, Dr. Swati, to please come up on stage to take over and run us through the neuro-ophthalmology at a glance. Again, thank you very much to all the panelists who've helped us in our discussions, and thank you everyone. Dr. Swati.
I will request our panelists to join me, Dr. Rebecca, Dr. Gazela, Dr. Neha Midda, and Dr. Anita Gankar. Rebecca, you can come on this side. Chair लगा देते हैं extra. So as we begin this session of neuro-ophthalmology, I would like to say there are two things common between strabismus and neuro-ophthalmology. One, of course, is cranial nerve palsies, which we deal with, in strabismology and also in neuro-ophthalmology. But apart from that, it's an application of brain, which is much more common between strabismus and neuro-ophthalmology. So as we begin this session, I would like to invite Dr. Neha Midda for the first talk on optic neuritis. It's the most common condition which we deal in neuro-ophthalmology. So I'll request Dr. Neha to begin her talk.
Good afternoon, everybody, and thank you so much for having me here. So I've been given 5 minutes to quickly do this. So my case is of a 10-year-old female who presented with sudden profound diminution of vision in both eyes since 2 days. There was no history of any ocular pain or headache. The only positive history was of gastroenteritis with fever 1 week back. So on general physical examination was all within normal limits. At the time of presentation, there were no signs of dehydration or no neurological deficit. All vital parameters were within normal limits. On ocular examination, she had presenting visual acuity of only PL positive in both eyes. Pupils were sluggishly reacting. Anterior segment examination was within normal limits in both eyes. Color, contrast, and visual fields could not be recorded due to poor visual acuity. So this was the presenting picture. We had bilateral disc edema suggestive of papillitis. And this was the baseline OCT, just confirming the disc edema. The neuroimaging, which is the baseline investigation that we definitely require, showed the enhancement of the optic nerve segments along with the slight perineural sheath swelling also at the anterior part. However, the rest of brain parenchyma was normal. Systemic examination, the CBC, serum electrolytes were within normal limits. We did run a chest X-ray and CBC to rule out if there was no active infection. The blood samples were taken for syphilis, toxo, and blood culture. So we started the patient on IV pulse steroids, methylprednisolone, 30 mg per kg, in 150 ml of ringer lactate over 45 minutes, which were given for 3 consecutive days, and followed by the 1 mg per kg oral steroids for 11 days. After 1 month, the BCVA was 6.6 in both eyes and color vision and contrast had recovered. This was the disc photo at 1 month, and this was the OCT. The disc edema had subsided, and this was the visual fields that were done at 3 months, which were absolutely within normal limits. So with a patient of bilateral disc edema who is coming to my clinic, there are certain things that will quickly run in my mind that will be like papilledema. However, I've ruled this out here because the vision loss will rarely be so sudden in cases of papilledema. For arthritic anterior ischemic neuropathy, the age group doesn't fit here. The patient did not have any headache or jaw claudications. I'm ruling out Leber's, and it occurs in males. So I came to a diagnosis of atypical optic neuritis, which was most likely to be followed by, due to a viral gastroenteritis the patient had. The recovery is usually good in these cases. So when I'm labeling my case as atypical optic neuritis, it is important for us to understand that what is a typical optic neuritis. So a typical one would most commonly present in young adults, especially in women. The visual loss will be unilateral. There will be spontaneous clinical improvement after 2 weeks, ocular pain, which is subtle on eye movements, and optic disc might look congested, and MRI may be normal in 40% of the cases. So anything that is not fitting into this picture comes under atypical optic neuritis, whether it is in the terms of visual loss or the age of presentation or the recovery. And also it is important that sometimes these atypical cases may be more steroid dependent. So just to summarize, if a patient with typical optic neuritis features walks into your clinic, what are we doing? So one thing, when you're suspecting optic neuritis, you run MRI, which should be with contrast. And if you're suspecting MS, you can definitely order a MS protocol. And after the MRI has been done and ophthalmic workup has been done and you have established a diagnosis of optic neuritis, you have to start the patient on steroids as per the ONTT protocol. That is 3 days of IVMP followed by oral. However, in clinical practice now we are, depending upon the recovery and the amount of visual loss, sometimes the IVMP may need to be given for up to 5 days also. Then now, depending what do you see on your MRI, if there is no other demyelinating lesion that is seen in the brain parenchyma, you can just follow up the patient. However, if there is no demyelinating lesion but the patient is presented to you with recurrent attacks, there is appearance of demyelinating lesions on MRI on the subsequent episode. So each time the patient is presenting to you with an episode of optic neuritis, it is important to repeat an MRI. Or if there is an appearance of any neurological associated symptoms, then a neurological intervention by a neurologist becomes extremely important. And if at the baseline itself we see there are demyelinating lesions, you have to refer the patient to a neurologist. You have to discuss with the patients the possibility of MS in the future and discuss the long-term therapy in the terms of interferon. However, if there is an atypical presentation, you have to tailor your investigations according to the presentation. You might not only need MRI brain orbit, but also spinal cord to look for transverse myelitis. You might need to run a MOG and an NMO antibody test, a CSF analysis, especially if you are suspecting an infection. You need to rule out the vascular inflammatory causes. However, it is important with most of the optic neuritis that is presenting to you, the IVMP will stay the mainstay of treatment. However, in non-responsive and very severe cases, plasma exchange and immunomodulators may need to be added. Thank you so much. Thank you, Dr. Neha, for that crisply summarizing optic neuritis. Yeah, it's very difficult to summarize it in 5 minutes. Any questions? Any questions from audience? Any comments from panel?
So I would just like to say here, we should remember all the points of typical optic neuritis. So whether your patient is fitting in that, if it is not fitting, then you have to look for the atypical. So Dr. Neha has very wonderfully explained about the atypical, how you go about that. So very important to remember those points.
Yeah. I would like to add that, earlier we were quite conservative with our investigation in optic neuritis. We would do limited investigations, but now as we are understanding optic neuritis more, and when newer and newer antibodies are being discovered in causing optic neuritis, so we have become little more aggressive in our investigation for optic neuritis. So as a first baseline investigation, what used to be like MRI orbit and MRI brain, we have now also added serum antibodies in form of NMO and MOG antibodies. So that gives us an idea whether how this optic neuritis is going to progress, because in those cases, in particular in atypical optic neuritis, you may have to give longer doses of not just IV steroids, but oral steroids also with slow taper. Right, thank you. So I'll quickly invite, any questions, please? Mike, please. Sorry?
I want to know, like, can a patient in young age, can a patient present with unilateral optic neuritis, disc edema, sudden loss of vision, can we give a course of steroids to a patient if we suspect that it is unilateral and it's a disc edema with sudden history, like a loss of vision for the history of 15 days.
Yeah,
After giving MRI, like after getting that MRI, should we go for steroid or not, even if the disc is like slightly edematous? We find that it is edematous.
Yeah, definitely. So in fact, in a high percentage of cases, you would find the disc might be actually normal, and we are looking at retrobulbar optic neuritis. So it is not at all necessary for you to have disc edema. If MRI is suggestive of that the retroorbital part of the optic nerve is also showing enhancement, it is sufficient enough to make your diagnosis and start the steroids. Yeah.
I just want to add one thing. The diagnosis of optic neuritis still remains clinical.
Yes.
So presence of RAPT, presence of disc edema, or even for that matter normal fundus, the diagnosis still remains clinical. The investigations are done to know the cause of the optic neuritis, basically etiology, to understand whether it's a typical one or an atypical, and also to prognosticate the patient. So if you have a clinical diagnosis of optic neuritis which does not fall in a typical one, you should give steroids. If it's a typical optic neuritis, if you don't want to give IV steroids at that point of time, it may still be justified. But nowadays, I think most of us are giving IV steroids because you don't know how the patient is going to prognose. Yeah, thank you. So I'll next invite Dr. Anita to present her talk on ischemic optic neuropathy, another common disorder in neuro-ophthalmology, commonly seen in elderly patients, and nowadays it's getting there are a lot of overlap of clinical features between the optic neuritis and ischemic optic neuritis.
A very good afternoon, everyone. Firstly, I would like to thank Dr. Rohit sir, Swati ma'am for this wonderful opportunity. It is a great honor to be at this podium after so many years. So I would be discussing ischemic optic neuropathy. Just briefly, one case, a 56-year-old male presented with a diminution of vision in the right eye, which was profound and sudden since last 3 days, and patient noticed it on waking up in the morning. No history of any photopsia floaters, no history of any headache, nausea, vomiting, no history of any scalp tenderness, myalgia, fever, no history of any ocular trauma, and there was no history of any smoking and alcohol intake. So past history was the patient had a hypertension and diabetes since 6 years. Diabetes was under control, whereas hypertension was not under control even with the medication. Family history, there was no significant family history. Systemic examination was within normal limit, and vital parameters at that time were normal. So on ocular examination, the positive findings were patient had a vision of finger counting 1 meter with PR accurate in the right eye, and in the left eye vision was 6/6 normal. So there was a presence of RAPD in the right eye. On fundus evaluation, there was a blurring of disc margins, disc was elevated, there was obscuration of cup, and the vessels were there was tortuous veins, and macula was normal. In the other eye, the fundus was normal, but there was disc at the risk. So the cup was small. Investigations, what we did, hemogram, ESR, CRP levels were normal, fasting blood sugar was 150. So while on BP charting, the twice daily, the BP was fluctuating, what we had seen, and then the lipid profile was deranged. So what were the differential? First was a non-arthritic ischemic optic neuropathy. Second differential in such cases is arthritic ischemic optic neuropathy, and then the optic neuritis. Ocular investigations in this patient, color vision was affected, contrast sensitivity could not be recorded because of poor vision, VER was extinguished, and Goldman visual field showed the fixation losses. So this was the OCT which showed increased thickness, sectoral thickness. So then what were the points in favor of NAION? Age, unilateral vision loss, suddenly noticed on waking up, predisposing systemic risk factor patient had, and there is a crowded contralateral disc, and then there is a sectoral involvement. So now coming to one related case which was not NAION, but like I would like to present here. So this was 47-year-old male patient presented with a diminution of vision in the left eye since few days, not associated with any pain, floaters and flashes, no history of any headache, vomiting and vertigo was there. There was no history of any trauma, and no systemic disease patient had. So patient was seen somewhere outside, and patient was there was a query macular lesion in the macula, and patient was advised OCT macula, and then patient came to us. So among the positive findings, visual acuity was 636, no further improvement with refraction. Left eye, I have seen the RAPD. And while seeing the fundus, there was a mild disc edema and with macular pigmentation. So diagnosis has been shifted from macular lesion to the optic pathology by just seeing the pupillary reaction. So RAPD was there. So even I have missed this proptosis. My colleague has noticed that there is a mild proptosis also in that patient's left eye. So on doing Hertel, it was 29 mm, which was other eye, normal eye was a 24 mm. So there was a slight difference in the values. So seeing all these parameters, imaging has been advised. So this was a fundus picture where you can see there is a slight pigmentation in the macular area, and there was a slight disruption of interior ISOS junction, but nothing significant in the macula it was. And on in the optic disc there was a edematous elevated disc. So OCT mild edema it has shown. Fields were not reliable because of fixation losses. So now here comes the MRI report, which showed that the patient had an orbital cavernous hemangioma large here. So the importance of showing this case is our clinical acumen, we should see the patient as a whole. So if the patient is falling in the category of NAION, but still there are few details which we should not miss, and we should see the patient as a whole, and we should see our differentials very closely, so not to miss any significant thing. So I'll just brief up in 1 or 2 slides. So optic disc elevation, if you are seeing, just rule out the true or a pseudo disc swelling. If it is true and you are seeing the increased intracranial pressure, papilledema. If the normal intracranial pressure, we have these main differentials. Either it is compression of the optic nerve, or it is ischemic or inflammatory, and very rarely the infiltrative causes can be there. So you have to go like this. So interior ischemic optic neuropathy, arthritic and non-arthritic both can be there. We should be very cautiously differentiating these two, because the prognosis of arthritic is very bad and the treatment should be very urgent. It is a medical emergency. So arthritic, fortunately, it is rare as compared to non-arthritic. It is about only in the 5% of interior ischemic cases. So this is almost the second last or last slide. So this you should remember by heart, that if you are seeing any ischemic optic neuropathy patient, just ask for these symptoms: jaw claudication, headache, scalp tenderness, myalgia, and any other symptoms. And the age, definitely the age is also important. And in arthritic, usually we get the profound vision loss as compared to the NAION patient. In my first case, it was profound vision loss that was atypical about the NAION in that patient. So every patient doesn't fall exactly in that category. So yes, so there are, the important thing is, if you are suspecting the arthritic or even in NAION, just go for the ESR CRP values, because treatment also, while giving treatment, you see these levels in the follow-up as well. So arthritic, aim medical emergency, as I already told, aim to prevent the blindness in the other eye. Steroid are the treatment of choice. We have to give IV pulse steroid as well as the oral steroid for a longer period, and response is tapered. The response is seen by ESR and CRP values, and sometimes immunosuppressives as well. So making the right choices while diagnosing and treatment is the crux of the discussion. So thank you so much. I would be happy if I can answer any of the query. Thank you.
Thank you, Dr. Anita. Any query, any comments from the panel, from the audience?
Ma'am, I wanted to ask, how often do you see subretinal fluid or neurosensory detachments following a non-arthritic ischemic optic neuropathy?
Yeah, it's not rare. I will not say that it's very, very rare. Sometimes you do see. It depends on the amount of disc edema you have. So if the disc edema is quite significant there, you will have associated neurosensory macular edema also.
And will you wait for its self-resolution, or would you like to intervene at some point of time?
It resolves as the natural course of NAION.
Okay.
I think NAION is a very common cause of sudden vision loss in elderly. but the management is very ambiguous. You know, most of the cases you're not able to do anything. So there's a lot of controversy regarding its management, shall we start steroids or not. So basically just identify, you look for the vascular profile of the patient, look for the vascular risk factors, lipid profile, diabetes, hypertension, and if that is the patient is non-diabetic, you can give the trial of oral steroids. So we did a RCT from a center for oral steroids in NaION, acute NaION, and we found that oral steroids, the final visual outcomes remain the same, but it just tends to hasten the recovery, you know, just like you see with IVMP in cases of optic neuritis. So you can start oral steroids in acute NaION if they are non-diabetic. In diabetics, probably you just, you know, there are very limited treatment options then.
Actually none.
Yeah.
Yeah.
So what is the dose of the steroids and how long do you give them?
We give 1 milligram per kg. We start with that and then taper.
For how long?
We maybe taper it in a month or 2. That's how you taper.
Yeah,
because the edema,
steroids actually help in decreasing the edema. It generally doesn't, as the study has shown, it doesn't, you know, help in visual recovery, final visual outcome. I think Dr. Rohit is here. He is the one who has conducted the study, so maybe his comments.
Thank you, ma'am.
Thanks. I would be very, very cautious in starting steroids, particularly if there is presence of systemic disorders like diabetes, hypertension. Diabetes is absolute no-no. Like I said, there is no clear evidence that it helps to improve final visual acuity. It has been shown to reduce the rate of the edema. Maybe if there is associated some macular edema, it may help us to resolve it better and faster. But again, like I said, it's almost, you know, I would say absolutely no if there is associated diabetes. But again, otherwise also there is an equivocal evidence that you should think in terms of giving steroids to NaION.
Thank you, sir. So we have covered the paralytic strabismus or cranial nerve pathologies in the first session. So in this session, we will cover the remaining aspect of the paralytic strabismus, that is supranuclear disorders. And Dr. Rebecca, who is assistant professor with us here, is going to speak on the supranuclear disorders.
Oh. Well, supranuclear disorders, well, it's a very interesting set of oculomotor disorders. And here, actually, you need to apply your brain. So I see a lot of people dozing off. You better, you know, try to just see carefully at the videos. Maybe it will just startle you up. Because we have we have compiled these cases for you guys to have a look at this. So this young female child, a female patient comes to us. So what you can see is that there is a bilateral limitation of lateral gazes, okay? So bilateral limitation of lateral gazes, the vertical gaze is intact. And if you look at her face, you can make out that the patient also has a facial palsy, lag of ophthalmos, drooping of the corner of the mouth. So the convergence is relatively intact. So this case has a horizontal gaze palsy and has a facial nerve palsy. So if you know your anatomy well, you can localize the lesion. So where do you expect the lesion? It would be somewhere in the pons, right? So in this case, we did a neuroimaging and we found a huge pontine lesion. Now coming to the anatomy, just brushing up this anatomy for you. So this is your pons. You can see that this is your horizontal gaze center. So what is the horizontal gaze center? Pontine paramedian reticular formation, and it is found in close association with these structures, as you can see, the 6th nerve and the 7th nerve and the fascicular part of this nerve. So if a lesion is present over here, it will definitely cause the involvement of one or more of these structures. So you see, if you know your anatomy, you can also localize the lesion. Then this is another second case. Just start the video. So another child, a younger child around 4-5 years, similar complaints, bilateral limitation of horizontal gazes. So you see the horizontal gaze is absolutely absent. Doll's eye is also absent. Pursuits and saccades were also affected in this. And if you look at the 9-gaze photograph of the patient, the vertical gazes are intact. And if you systemically, when we examine the child, so this is an interesting phenomena. What you see on this is a synergistic convergence. So that is a very rare and interesting phenomena that you can see only in certain entities, that on attempted lateral gaze, the child is actually having a convergence. Rather than the lateral gaze, the child is actually having the convergence. So that is a synergistic convergence. So if you see carefully, that's the convergence happening on attempted lateral gaze. And she also had scoliosis. And this is the elder sibling who also had similar complaints of bilateral horizontal gaze palsy, but the scoliosis was much more severe. So here the patient has a bilateral horizontal gaze palsy and scoliosis. So what is this? Again, we get the neuroimaging done. And what we find is that the brainstem is hypoplastic. So you see this, this butterfly-shaped medulla, then there is the split pons. So this is a congenital anomaly. That is horizontal gaze palsy with progressive scoliosis. And it's been attributed to ROBO3 gene mutation. And in this case, it was found to be positive in both the siblings. So this we are underway, publishing this case in JAPOS. And as I just told you, it's autosomal recessive condition. It is classified as CCDD. And since the ROBO3 gene mutation is responsible for the decussation of white matter tracts, and that's why because of this problem with the decussation, these conjugate horizontal eye movements are affected, and so does the scoliosis develop. But the onset of scoliosis happens a little later in childhood. So it's a rare anomaly. Now, third case. So this is a young gentleman. We can see that right gaze is normal, but on left gaze, what do you see? There is a limitation of adduction, and this is quite characteristic. So what is this? Any guesses? Sorry? So there is a limitation of adduction and abduction nystagmus in the other eye, but convergence is intact. Exactly. So this is a case of internuclear ophthalmoplegia. So what do you expect the lesion? Exactly. Medial longitudinal fascicular. So here again the anatomy helps you. So when we did the neuroimaging, we found a pontine infarct in the patient. Just in continuation with this case, just like we saw the case of iron node, just see this case. There's a patient, no deviation in primary gaze, vertical gaze normal. But what happens in the left gaze? It's a left gaze palsy. In the right gaze also, there was limitation of adduction and abduction nystagmus. So 3 movements in horizontal gazes are gone, and only half of the movement over here is left because, it's an abduction nystagmus. So it's a 1.5 syndrome. So where do you expect the lesion here? It's actually a combination of a gaze palsy and internuclear ophthalmoplegia. So it has to be involving both, a more diffuse lesion which is involving PPRF as well as MLF. So a more diffuse lesion. So now just, and we did the neuroimaging, and of course you can see that there is a diffuse lesion involving the brainstem. It was a huge metastatic lesion, and the primary was found to be in the kidney, and this case was published in IGO, Indian Journal of Ophthalmology. So coming to the anatomy of the horizontal gaze pathway. So if you look at it, PPRF present in the pons, that's a horizontal gaze center. So this is your, somewhere lying in the pons, your horizontal gaze center. From there, the impulses travel to the abducent nucleus. This is also present in the pons. Now, from the abducent nucleus, how do the impulses travel? To the ipsilateral lateral rectus, they will go via the abducent nerve. And to the contralateral medial rectus, it will reach via the MLF. So this MLF is the interneuron which is carrying the impulses from the abducent nucleus on one side, travels all the way up from the pons to the midbrain, and is supplying the oculomotor subnucleus, the medial rectus subnucleus in the midbrain. So anything happening in the MLF will cause a internuclear ophthalmoplegia, but a diffuse lesion that can affect all this structure here, this will cause a 1.5 syndrome. So that's your anatomy. So this majorly covers all your horizontal gaze disorders that you would see. Now coming to the vertical gaze disorders. Now this is a middle-aged man. As you can see, all gazes are essentially normal, including the down gaze, but what is affected is the up gaze, right? So now coming on to the video. So look at this, the down gaze is normal, but on up gaze, there is a limitation of up gaze. But there's another unusual finding. If you look at it, you can clinch the diagnosis. What is that? What is this happening on attempted up gaze? Yeah, what nystagmus? Convergence retraction nystagmus, exactly. So that gives you the diagnosis. So clinical diagnosis is, it's a case of dorsal midbrain syndrome or a Perinaud's syndrome, right? So what are the other features of dorsal midbrain syndrome? You would also see a pseudo-Argyll-Robertson pupil. So what is that? Where there is an impaired response to light reflex, but very intact response to accommodation reflex. So pupillary responses to accommodation you can see is good. However, in response to bright light, it is slightly present, but it's kind of impaired. That's why it's pseudo-agile and not a true agile Robertson pupil in Perrin-North syndrome. So your diagnosis gives you the site of the lesion, dorsal midbrain syndrome. So you expect something in the dorsal midbrain. We get the imaging done, and we do find this lesion in the dorsal midbrain. So this was a case of a penialoma. And just coming onto the vertical gaze pathway. So what is the vertical gaze center? It's the rostral interstitial nucleus of MLF. Now from there, your impulses are passing via the MLF to the superior rectus and inferior oblique subnuclei, which is present in the third nerve nucleus complex. Crossing over is happening in the posterior commissure and then supplies both the elevators of the eye. Now if something happens in the posterior commissure, it will lead to the dorsal midbrain syndrome. Now let's have a look how the pineal gland can cause a dorsal midbrain syndrome. So you see this is the pineal gland and that's the posterior commissure. So pineal gland is present in very close association with your posterior commissure, right? So if any tumor is enlarging the pineal gland, it will definitely compress your posterior commissure and cause your dorsal midbrain syndrome. So I think we have shown you a wide variety of cases in the limited time we could. So just remember that supranuclear disorders, they constitute 10% of ocular motility disorders, although rare but not very uncommon. So you must look for the unusual signs. If you know the anatomy, you have a thorough understanding of a neuro-ophthalmology, you can identify or pick up these subtle signs, and actually you can identify, localize the site of your lesion, and you can actually guide the radiologist as to the possible site of the lesion. Thank you.
Thank you, Dr. Rebecca, for wonderfully illustrating those interesting cases of supranuclear palsies. Can we have any comments from panel or audience? Dr. Gunjan, you want to say something? Dr. Amar, there. Okay, I just want to add something to Dr. Rebecca's clinical, because clinical evaluation in these cases is very important. So doing involuntary reflexes is important. Examining reflexes is very, very important, like doll side movement, like Bell's reflex. So that will help you in differentiating whether the lesion is supranuclear or infranuclear. So that's one very important. So in your clinical examination, let's not forget to do those important tests. So next is misdiagnosis in neuro-ophthalmology. So there are a lot of cases which are misdiagnosed in neuro-ophthalmology, wide range, including from retinal cases to glaucoma cases, and sometimes even refractive errors have been misdiagnosed as and referred to neuro-ophthalmology clinic. So we have with us our ex-SR, Dr. Gazela, who has recently joined as assistant professor in RML. She will be taking us through the journey of all these misdiagnosed cases in neuro-ophthalmology.
Thank you, Swati ma'am. So today I'd like to say that I feel like a resident for two reasons. First of all, for again standing in this podium, and second for relearning strabismus after more than 2 years, after predominantly practicing glaucoma. So today I'd like to discuss mainly about how many cases are being misdiagnosed as either glaucoma, if they are not glaucoma, or the other way around, and hope that the crosses to these two departments will reduce. So, of course, it is easier if the IOP is high to diagnose it as a case of glaucoma, but if it is in normal range, that's when the difficulty starts arising. So, a few differences between the two. Of course, all cases will not follow this. Glaucomatous optic atrophy usually is more in elderly, and color vision is usually preserved till the last stage. And the central vision is not really affected in glaucoma, whereas in non-glaucomatous it will be. And usually in early glaucoma, moderate glaucoma, the pupil reaction will be normal, whereas in non-glaucomatous there will be presence of RAPD. So in glaucoma, in the usual glaucoma cases, we'll see presence of excavation as seen here, or presence of notches or RNFL defect, or disc hemorrhage, which is more common in normal tensional glaucoma. And also there will be correlation between the disc findings and the visual field defect, as we can see here, whereas in case of non-glaucomatous, there won't be much correlation. So non-glaucomatous, mostly we will see presence of pallor more than the cupping. And if we see diffuse pallor, there will be diffuse loss of RNFL, or there might be presence of sectoral pallor. And also the corresponding visual field defects in these cases. So we'll start with the congenital conditions which we might misdiagnose as glaucoma. These are presence of optic disc coloboma as seen here, which may look like a glaucomatous optic atrophy, optic disc pit, and even morning glory syndrome. But if we know all these features properly, we will not be able to misdiagnose them. So we go to the first case. This is a 48-year-old male who was diagnosed with glaucoma elsewhere, and he was on glaucoma medications. He didn't have any family history or history of use of steroids. As we can see here, he had 20/20 vision, and IOP was normal. He was on glaucoma medications. He had open angles, and CCT was also slightly thicker. If we look at the optic disc findings here, we will see a very large optic disc. We may think that these are excavations which we see in both the eyes, but we will see that the RNFL is actually normal superiorly and inferiorly in both the eyes, especially on red-free filter, and the visual field was normal in both the eyes. So this patient actually had megalopapilla. This is a large optic disc with large optic cup, and usually these patients will have normal HVF. So case 2, a 57-year-old male who was diagnosed as a glaucoma suspect, and he did have family history of glaucoma in the father, and he said that the father was diagnosed at the age of 80 years, and he had good vision till that age. So we see that he has 20/25, 20/20 vision, and also both his pupils were normally reacting. If we look here at the optic disc, again we will see that it is a severely tilted optic disc, both eyes, and it may seem that there is excavation inferiorly, but again if you look carefully, the neuroretinal rim in both the eyes is pink and seems to be healthy. And this was the optic disc photos which the optometrist had uploaded. He was also slightly confused which is the right eye and which is the left eye, as we can see here. So this is the actual right and left eye. So this is a case of situs inversus. So these cases might have enlargement of blind spot, and we should not treat these patients as glaucoma and follow them up and check the IOP. So situs inversus, as we can see in this photo here, there is nasal, there is abrupt turn of the vessels at the temporal side, and this is due to disversion of the optic nerve head, and there is nasal direction emergence of the blood vessels. This is due to an abnormal insertion of the optic stalk into the optic vesicle. So another case, a 29-year-old female who had blurring of vision in both eyes, and she was very distressed. She was like, she was not understanding why she was experiencing these symptoms. And she had 20/20 vision in both eyes, normal eye pressure. She had already consulted elsewhere, and they had already done a visual field and an MRI before she had presented. So these are her optic discs. As we can see here, again, the superior and inferior RNFL seem to be normal in this patient. But if you'll also notice the nasal part, there is darkening of the RNFL here. In her visual field, although the left eye seemed to be normal, the right eye had this inferior visual field defect, which was there even in the previous visual field which she had done elsewhere. And if we did an OCT, which showed mainly supranasal thinning in both the eyes, even though in the left eye she did not have any visual field defect. So even on GCC, she had a more of supratemporal thinning, and we were slightly confused with the diagnosis, so we had ordered a few investigations also because she was very distressed. She was not willing to accept any diagnosis. So we found out after a few blood investigations that she did have vitamin B12 deficiency. So even I'm slightly confused with this diagnosis, but I think that it is superior segmental optic hypoplasia with coexisting nutritional optic neuropathy. So SSOH is a congenital anomaly, and it has been shown that it is more associated with mothers who have diabetes. So this patient, of course, her mother did have diabetes after we later on asked her retrospectively. So SSOH, there is a superior peripapillary scleral halo with thinning of the superior RNFL, and there is superior entrance of the central retinal artery. So it is similar to NTG because there is rim thinning and the NFL defect, but it is different because the thinning is in the superior nasal region, and there is no progression with time as seen here. So, and the thinning is more in the superior and supranasal segment, which is opposite to NTG, which is temporally, and GCC will be more supranasal and intranasal. So the last case is a 56-year-old female who had decrease in vision in the left eye for 6 months, and she had no family history of glaucoma and no history of use of steroids. So vision in the left eye was reduced and color vision was also deranged, although the eye pressure was normal. If you look at the optic disc here, there is more of a, although not very much appreciated, more of shallow cupping and pallor, also seen on the red-free filter. And this is the visual field, which seemed to be more of a neurological field defect, but we had done an MRI which was normal, and then after re-examining the patient, we found that she had pupillary rough atrophy with iris atrophic patches, and on doing a gonioscopy she had occludable angles with synechia. So we finally diagnosed her to have a chronic PACG. So this can also be difficult to diagnose because these patients may have diffuse pallor with shallow cupping, and we need to take a detailed history and examination, and if we do still have suspicion, we should rule out other modifiable risk factors. So the take clinic message is that we should do a proper history taking and revisit the history after we have come to a differential diagnosis, and do a careful examination of the optic disc with, of course, color vision, contrast and pupil reaction. And we should correlate the visual field and advise any proper investigations after we have come to a differential diagnosis. Thank you.
Thank you, Dr. Gazella. Any comments, panelists?
So it is, we often say that, that neuro-ophthalmic diseases were misdiagnosed as glaucoma and patient was started on AGM, but it is not uncommon to see other way around also, especially in patients who have angle closure glaucoma and have had repeated attacks of high intraocular pressure. It is often that they would have shallow sloping cups with optic disc pallor, and then they are misdiagnosed as both high disc pallor and we let them go. So in those cases where seeing pallor, it is important, and if you do gonioscopy and see that there are no other signs of angle closure and you are not misdiagnosing or leaving glaucoma undiagnosed.
Yeah, I think another condition which has quite confusion with glaucoma, open angle glaucoma particularly, or low tension glaucoma, is compressive optic neuropathies, which we need to keep in mind whenever you have, normal pressures with large cup. So these are the cases which may have intracranial lesions, especially chiasmal lesions, pituitary adenomas, and because of the chronic compression there is loss of axons, which ultimately leads to cupping. So that thing needs to be kept in mind whenever you are dealing a low tension glaucoma with enlarged cups. Secondly, there are retinal cases, quite some retinal cases where you just have disc pallor. So I would like to know the view of panel. How would you go about such cases where you just simply have a disc pallor? So it has been referred to you. So how would you like to go? Will you do all the investigations? What would be your approach towards such cases?
Basically, ma'am, in those cases, we have to see the first history, the age of presentation. That is very important. Many a time, if the bilateral disease is there, but it is a very chronic type of thing, we have to surely rule out the causes, like diseases like LHON. If child is presenting to you like in a teens, 12 to 15 years of age, and you have the disc pallor, but then you have to see the associated things as well as how the vessels look like, what is the history, are there any episodes of improving vision in between, what is the family history of that patient. So multiple, you have to see the patient as a whole, and then definitely the investigations will add up to the things.
Right. So the investigation, you did not investigate each and every patient. That's the first thing. Or sometimes just doing a color vision and contrast vision will tell you whether this patient has any optic nerve associated issues or not. The second important thing, if you are not so very convinced with your clinical examination, then you may probably go to electrophysiology, which will definitely help you in differentiating between a retinal disease and an optic nerve disease. So multifocal ERGs, or even for that matter full field ERGs, are good way to, we can use them to differentiate. Nowadays even OCTs are being done so regularly, and you may have very subtle lesions, just disruption of iOS junction or disruptions of photoreceptors there, absence of photoreceptors, or any other abnormality, subtle abnormalities may be picked up on OCT that will help you in deciding whether it's a retinal issue or an optic nerve disease. Right.
Ma'am, investigations like OCT and VPs, definitely they help in diagnosis, plus they help in telling the patient the prognosis of the disease. Like how much already the damage is there.
Yes.
And you cannot just simply go away saying that nothing can be done. Like, and if you will tell the patient in detail the prognosis, seeing the VP and OCT, GCL layer thickness, the damage already is there, then it would be good for the patient also, that he would be knowing the disease better.
Right. Thank you.
So we have a next talk by Dr. Swati Fuljale, who has been an associate professor and the pioneer of Neuro-Phthalmology services at our center. So, so I think she would be discussing about IIH.
I would like to apologize for that. I can't take credit for starting Neuro-Ophthalmology services in the center. That credit goes to Dr. Menon. She is the one who actually started it, and I think we all are following her dictums. We all are following whatever she has taught us. So I would be talking about idiopathic intracranial hypertension, which was earlier known as benign intracranial hypertension, but we all know it's not as benign as it sounds or looks. So since it's a case-based approach, I'll be showing you two endpoints of a spectrum of IIH. So this was a first case where a 40-year-old lady presented with headache. The headache was diffuse and very severe, especially it made her awake at night and was extremely worse in morning. It increased with head movement, coughing or straining, and is associated with nausea, vomiting. Photophobia may or may not be there. So there was also history of transient obscuration of vision. So this is a very classic history for a patient of idiopathic intracranial hypertension. So as opposite or as contradictory to optic neuritis, where you have immediate loss of vision, the patients of IIH do not have immediate loss of vision. They generally begin with transient obscuration of vision, and this sometimes we forget to ask in our history. So you must ask whenever you have a case of bilateral disc edemas, please ask for history of TVOs. There can be associated symptoms like tinnitus and diplopia, although those were not present in this particular case. There can be history of weight gain and endocrinology abnormalities, which we should not overlook and should make it a point to ask in our history, and that was also not present in this particular case. But on examination, she definitely was obese according to the classification, international classification, but there is a separate classification for the Asian population. On examination, she had very good vision of 6.9 in one eye and 6.6 in other eye. Her pupil reaction was absolutely normal. But this was her fundus. So you can see that there is a very significant disc edema over there. There is no doubt about the disc edema. So this is a very established case of papillary edema. On investigation, there is enlargement of blind spot, which is a classical feature of papillary edema. And on OCT, there you can see how raised RNFL is, how thickened it is. So you have to do MRI in these cases, because not all cases of papillary edema are idiopathic intracranial hypertension. Many of them will have some intracranial lesion, specifically space occupying lesion, and that needs to be ruled out. So in any case of papillary edema, MRI becomes mandatory, both brain and orbit. Apart from ruling out intracranial space occupying lesion, MRI also helps in substantiating the diagnosis of IIH in form of features like you have a dilated nerve space here. The sheath is dilated and there's a fluid here. So it's a T2 image. I'm sure in the other talk it will be discussed how to interpret these images. So you can see that the sheath is absolutely dilated and quite some fluid over there. The other subtle sign is the partially empty sella, which is not very specific, but yes, gives you a clue about the IIH. Then you have a flattening of the globe over here, which is also a significant sign as far as the raised ICT is concerned. In doubtful cases or in cases where you are suspecting a cortical venous thrombosis, you must do MRV also to rule out the cortical venous thrombosis. So the diagnosis of IIH is mainly clinical, and it is diagnosis of exclusion only when you have ruled out all other causes of raised ICT, particularly space occupying lesions and intracranial infections like meningitis or encephalitis. So there is a classical modified Dandy's criteria which says that you should have a papilledema, but other neurological examination has to be absolutely normal except for the presence of abducens palsy. Then there should be the presence of raised CSF pressure more than 250 mm of water, and other than that there should be no other cause of raised ICT found. There is a recent criteria which is a Friedman criteria, which is more or less similar to modified Dandy's criteria, but they have also added there can be IIH without papilledema, although it's not so common, but yes, not unknown. And then in this case, you will have all other features of papilledema. Apart from that, you will have certain signs on neuroimaging to say that this is a case of IH. And in still those cases, you have to rule out the other causes of raised ICT. So in this patient, the CSF pressure was just borderline raised. This was 27 mm of water. So management, of course, if you can find a cause of raised ICT, the removal of cause is the primary management. But in cases of IIH, weight loss has become a part of the management protocol, and along with the medical and surgical management. The idea is to prevent the vision loss, which is the major disability of the IIH patients, and headache. So this patient was managed. She was given a diet chart. She was asked to do certain physical exercises because it was seen that, you know, around 6% to 15% of weight loss can lead to early resolution of papilledema. But that alone is not sufficient. So you have to give patient acetazolamide, which is the treatment of choice in cases of raised ICT, whether it's idiopathic or otherwise. So to begin with, we started her with 250 milligram of TDS, 250 milligram TDS, and increased it gradually to 1.5 gram daily. But if patient is not responding, the maximum recommended dose 4 gram can also be given depending on the requirement. We have to understand that this acetazolamide has its own side effects like paresthesia, lethargy, and hypokalemia, which can be very detrimental to patients. And many of these patients, in fact, studies says that as many as 50% of these patients may stop acetazolamide because of the side effects. So you need to counsel them properly and give them supplements as well. So after 2 months of therapy, you can see that the disc edema has resolved. It has come down, although not completely gone away. And you can see that the OCT picture at 2 months, you can see that edema is still there but has substantially reduced, and at 6 months it has become almost normal. So this case tells us that appropriate management, timely management can, you know, help in preventing vision loss in these cases. So there's this second case where a 30-year-old female presented to us with gradual progressive. So as I was emphasizing that these patients generally have gradual loss of vision and not the sudden loss of vision like other optic neuropathies where the vision loss is quite sudden. So it's a gradual loss of vision, bilateral, simultaneous, and there's a progressive worsening of the vision loss. On asking the history, she definitely said that there is history of transient visual obscuration, and there was a history of episode of improvement of vision after one lumbar puncture. There was no pain, nothing. Headache was there definitely, and it was severe and worse on awakening. There was history of weight gain in the recent past. So there was also the history of previous treatment of acetazolamide given 250 milligram TDS. So, and there was also history of one lumbar puncture, which was diagnostic as well as therapeutic. So in ocular examination, you can see her vision was extremely poor. Since the optic nerve is almost now compressed because of the raised ICT, the vision was extremely poor. The pupil was very sluggishly reacting. There apart from that, rest of the anti-segment was normal. So on posterior segment, you have this kind of a picture where the edema also, although seems to be resolved, but there's a severe pallor over there, and it's in the atrophic stage. So that was an established stage. This is an atrophic stage of papillary edema. So CSF opening pressure was measured. It was around 30 centimeter of water, and rest of the CSF composition was normal. On MRI, you can very nicely see that how distended the sheath is and how much fluid is there around the optic nerve. So in this case, you can see that the OCT showed, even though the RNFL is not normal, RNFL is normal, it is not that thickened, but what you need to look at is GCL. Look at the amount of the damage that has been done to GCL because of that chronically raised ICT, right? So just going by RNFL may give you a false sense of security. It may tell you that, you know, there is no edema, everything is okay, but you have to look for GCL to understand that there is a concurrent GCL thinning as well, which is the cause of loss of vision. So management, again, the principle remains the same: weight loss, medical and surgical. But here we had to increase the dose of Diamox and see whether the patient responds to it or not. However, patient did not respond very significantly, and the patient's vision was very, very poor. We wanted to do the surgical management, and the indication was acute or rapidly progressive optic neuropathy or the medical treatment failure. There are three choices of surgical procedure that you can do. You can do a CSF diversion with shunting, you can do optic nerve sheath decompression, and you can do venous stenting. Particularly if there is cortical venous thrombosis. Sorry. So this is a video to show how we approach what is the surgical approach for ONSF. So as a strabismologist, it's quite comforting to, we are quite comfortable in doing the medial rectus, hooking it, passing sutures. So we want to go through the conjunctival approach, which helps us in quite wide exposure of the optic nerve. So the medial rectus is hooked, secured, and then disinserted. The non-absorbable sutures are passed through the stump of the medial rectus insertion. These are the non-absorbable sutures. They are used for the traction of the globe when you want to expose the optic nerve, because it's quite posterior and medially. So once that is done, optic nerve is expressed, and it is identified by the presence of vessels, short posterior ciliary vessels, as well as central retinal arteries and veins. There is quite some bunch of vessels over there, and sometimes needs good amount of exposure to identify or to approach optic nerve. So you can see vessels over there. You have to move those vessels either with the lens hook or whatever instrument you want to use. And you can see the gush of fluid coming out of the fenestration. So you can use keratome. I have used MVR blade. You can use 2.2 keratome also. And it's important to make the window over there so that this small fenestration doesn't close, because it is going to close over the period of time. And once that is done, you reinsert the medial rectus and close the conjunctiva. So at the discharge, her headache had decreased, although ONSF doesn't cause so much relief in headache, but maybe subjectively it had decreased. Her vision improved little bit, from hand movement improved to 1/60, but at 2 months there was quite significant improvement in vision. However, the fundus will still show the disc pallor, but the amount of edema is definitely resolved. So now the patient was able to have some visual field also along with the vision. So sometimes doing surgical intervention at appropriate time will help patient in rehabilitation. So just to summarize, if you have a clinical features are suggestive of idiopathic intracranial hypertension and papillary edema, please do your neuroimaging, MRI both and MRV both to rule out intracranial lesions as well as CVT, do lumbar puncture to rule out inflammatory, infectory causes and to document the raised CSF pressure. Also rule out the secondary causes of IIH, specifically endocrinology abnormalities like hypothyroidism, PCODs, hypervitaminosis. They should be kept in mind. As far as management is concerned, if you have minimal vision loss, you can continue with your medical management, particularly acetazolamide and weight loss. If you have a CSF, severe vision loss, then you have to do ONSF. But you have a headache, which is a prominent complaint, prominent symptom. In absence of very significant vision loss, CSF diversion is the procedure of choice. With that, I conclude. Thank you. Any questions? I'll be happy to take. Any questions from panel?
So ma'am, for patients who are primarily like first presenting to an ophthalmologist, and you clinically and radiologically you establish that it is a case of IIH, is it mandatory to get a LP done?
I will not say it is absolutely mandatory, but it's always better to document, you know. But yes, there are fallacies with LP also. Not every time you may get a high pressure. It depends how it was done.
Yeah.
Right. So if it's done in a proper way, it is you will get the high pressure.
Yes.
But having said that, you know, it's not absolutely mandatory, but what is more important is to document, because over the time, you know, there can be issues if you don't document CSF pressure. And it's not just important for documenting the raised CSF, it's also important to rule out the other infective or inflammatory etiologies which are there, and in those cases CSF composition is what is mandatory.
Okay. And ma'am, how do you practically prognosticate these patients when they walk into your clinic? Like, what do you tell them for how long you will need to take Dimox? And you know, like, not many cases we see who need surgical. We are able to manage a lot of them medically only. So, but what is in your experience, and how long do we tell them they would need to be on medications?
See, generally that depends on number of factors. How severe was the disc edema to begin with? If you have a severe disc edema, of course you will need more longer duration of acetazolamide therapy. But what is more important, that patients, in our study we have seen that patients who have weight loss, say for 6 to 10%, show early resolution of papillary edema, and their vision is quite maintained for some time. Then depending on the resolution of disc edema or papillary edema, how it is responding to your Dimox therapy, you can start tapering. But for initial 3 to 4 months, you definitely will have to give it as full dose. Then if the edema has resolved, you can consider tapering it. Again, you have to do fundus examination and visual field. Look at the blind spot, because blind spot gives you a lot of information about the status of the IIS. So if it started reducing, then you may think of tapering. But many of these patients also recur. It's not that, you know, you have stopped Dimox and the patient is happy once for all and is done with it. No, so they will come back. They will come back even after optic nerve sheath fenestration. So it's just a temporary measure to tide away from that till a definitive treatment is done for this patient.
Okay, thank you.
What is the alternative drug which you give Dimox, in a substitute of Dimox, which take care of headaches more? You were
Topiramate can be given.
Yes.
Right?
So when you decide in which patient topiramate you can give?
See, generally many of these patients have very good response with acetazolamide, but they sometimes even improve. So we don't start it, we refer it to neurologist, and neurologists are the one who start them on topiramate, because topiramate helps one in relieving the headache, and also to certain extent, you know, helps in weight reduction.
So that can be given in addition to the Dimox?
That can be given in addition, and sometimes also can be an alternative to Dimox, where patient is at all not tolerating acetazolamide.
Yes,
thank you.
Thank you.
So we next have a very good interesting talk on neuroimaging. Unfortunately, Dr. Sanjay Sharma could not join us, but we have Dr. Sharath here, who would be taking us through this talk. And as we all know, radio neuroimaging is a very, very important thing. It's not just sufficient to order what neuroimaging, but it's also important to order what type of neuroimaging and how to interpret it.
Good afternoon, everyone. And I'll be talking about imaging of optic nerve. So we're going to discuss about radiological anatomy and MRI sequences and how to identify the MR sequence, and we'll see some cases about demyelinating conditions, neoplastic like gliomas and meningioma, and we'll see some features of idiopathic intracranial hypertension. So coming to the radiological anatomy, so optic nerve is a 5 centimeter structure. So it is divided into 4 parts. The first part is the intraocular part. This is the shortest length segment of the optic nerve, and it continues as an intraorbital part which is shown in the arrowhead. So it is the longest part of the optic nerve, and there it enters the optic canal. And this is elbow arrow showing the intracannular part, and it is the segment within the optic canal. And after that it enters the suprastellar cellular cistern, and it joins with the opposite optic nerve to form optic chiasma. So the before forming chiasma, this part is called prechiasmatic part. So optic nerve is basically divided into 4 parts. So look at the optic nerve per se. Here the dark signal structure is the optic nerve per se, and the surrounding is optic sheath, and optic sheath is nothing but a extension of subarachnoid space. So what are the imaging modality used for the evaluation of optic nerve pathologies? So CT mainly it's not a modality of choice for optic nerve pathology evaluation, but in cases of traumatic optic neuropathy we can use to see the diameter of optic canal or any bony fragment within the optic canal. So I'm showing the one case. It is a RTA case with complaints with the loss of vision on the left side. So here we can see this is the optic canal. This is the right side, this is the left side. Here we can see there is a fracture of medial wall of the optic canal, and we also see a bony fragment which is within the optic canal. So this is the cause of traumatic optic neuropathy. So similar finding also seen on the axial images. So MRI is the modality of choice for optic nerve pathology evaluation. So we'll see some sequences which help in evaluation of optic nerve. This first we acquire T1 weighted axial and corneal images which is non-fat side. So this is the axial image, this is the corneal image. So why I am saying it is T1 weighted? See at the globe, see the vitreous, it is dark signal. So it's a T1 weighted image, and see the retroorbital fat, it's bright. So this is a non-fat side T1 weighted image. So we'll then acquire T2 weighted fat side axial and corneal image. It is mainly to see the pathology per se. So this is the axial image, this is the corneal image, and look at the vitreous, it is bright. So it is a T2 weighted image, and see the retroorbit, there is we can't see any retroorbit fat. So it is a fat side image. So it is a T2 weighted fat side image. And this is an optional sequence we can acquire. It is planned along the optic nerve. So that we can see entire length of optic nerve from intraocular part till the chiasma in one image. So this is an optional sequence. We can skip or we can include in our. So these are we also then we acquire post contrast T1 fat side axial and corneal image. So why I am saying it is T1 weighted, because vitreous is dark, and see at the extraocular muscle, this is a lateral rectus, this is a medial rectus, which is showing enhancement. So it's a post contrast image, and normally the optic nerve doesn't enhance on post contrast image. So when we say optic nerve is abnormally enhancing, when it is enhancing equal to or greater than that of an extraocular muscle. So point to remember is, to say it is abnormally enhancing, we need to compare with the extraocular muscle. So if it is enhancing equally or more than that of extraocular muscle, then it is called abnormal. So these are the conditions mostly associated with demelting conditions. So to see, we also screen for brain for white matter lesions and also for infarcts. So in brain screening, we mainly take FLAIR and DWI. This is a FLAIR image, so it better depicts the white matter abnormalities, and DWI in case of any infarcts involving the visual cortex. So we also screen spine. So we mainly take T2 weighted non-fat side image. So why I am saying it is T2, because see at the subarachnoid space which is surrounding the cord, it is bright, so it is a T2 weighted image. So just for identifying the sequence, this is a T1, this is a T2, and this is a FLAIR. So whenever we see a MRI image, look at the fluid field structures. In case of orbit, we will see at the vitreous. So in case of spinal cord, we see the subarachnoid space. So in case of brain, we will see the ventricles and subarachnoid space. So see at the ventricles, it is bright signal. So it is a T2 weighted image. So if the ventricles are dark in signal, so it can be a T1 or a FLAIR. Then we need to see the white matter. This is the gray matter, the convoluting part, and this is the white matter. So see at the white matter, it is bright. So if the ventricles are dark and white matter is bright, so it is T1 weighted. So if the ventricles are dark and white matter is dark, so it is FLAIR. So FLAIR is nothing but a T2 weighted image with the fluid signal suppression. So this is a cis sequence. It is a heavily T2 weighted image. So this is also we routinely not use. So it is mainly used for inner ear structures or cranial nerves evaluation. But we can sometime we can use to evaluate the optic nerves. So this is a case of raised ICT. So here we can see this is the optic sheath, so which is prominent bilaterally, and also see at the optic head it is showing protrusion. So it is equivalent to the clinical finding papilla edema. So this is a case of raised intracranial pressure. So even on ultrasound we can say the raised intracranial pressure. We need to measure the optic nerve on USG 3 mm posterior to the globe. And if the optic nerve measures more than 5 mm, then we can raise the possibility of raised intracranial hypertension. So we'll be seeing some cases. This is a middle-aged woman with a left vision loss. So see at the this is a stir sequence. This is a T2 weighted fat side image, coronal sections. So see at the left optic nerve. So it is showing bright signal when compared to the left side. And this is a post contrast image. Look at the optic nerve on the left side. It is showing enhancement similar to that of extraocular muscle. So this is definitely abnormal. This is suggestive of left optic neuritis. So on SAG FLAIR images, we can see there is ovoid shaped white matter abnormality in the callososeptal interface, and also some subcortical white matter abnormalities. So this is a FLAIR image. So these are the typical of multiple sclerosis. So this was a case of multiple sclerosis with left optic neuritis. And how you diagnose multiple sclerosis? It's mainly by McDonald's criteria, which was revised in 2017. So coming to the case 2, this is a 11-year female child complains of paraparesis, right eye vision loss, which is followed by left vision loss, and in that patient anti-MOG was positive. These are the post-contrast corneal images. See at the bilateral optic nerve, these are the optic nerves which is showing enhancement similar to that of extraocular muscle, and it is also involving the prechiasmatic part, this one. So it is involving long segment. These are the SAG images. See that optic nerve is involved in entire course. This is a long segment, which is long segment involved in the optic nerve, mostly seen in MOG type and NMO AD type of demelting conditions. This is the right side and this is the left side. So bilateral optic nerve, long segment involvement. Coming to the brain T2 weighted image, this is a axial image, this is a SAG image. See at the pons there is a white matter lesions in pons as well as in midbrain. And on spinal cord we can see the thoracic dorsal spine is swollen, and we can see a cord lesion. So usually in a MOG there is long segment involvement of cord which is more than 3 vertebral segment. Usually central cord is involved. So this was a case of MOG with this is with bilateral optic neuritis. So how you diagnose MOG? It is mainly by a MOG antibody demonstration of MOG antibodies and clinical features. Coming to the case 3, this is a 5-year male child with altered sensory and vision loss in left eye, and in this patient anti-aquaporin 4 was positive. These are the flare images. We can see extensive white matter lesions. So in the middle cerebral peduncle, bilateral basal ganglia, subcortical white matter, centrum semioval, and some subcortical white matter. So mainly in NMO there is mainly involvement around the 3rd and 4th ventricle, and hypothalamus is mainly involved, and optic nerves, because the density of aquaporin 4 are more in these structures. So here we can see this is a contrast enhanced T1 weighted image. See that the bilateral optic nerve is showing enhancement similar to that of extraocular muscles. So in T2 star image we can see left optic nerve is mildly thickened and showing hyperintensity. And this is a post contrast image showing similar findings. On cord we can see cord altered signal intensity in the cervical cord. It is short segment, but usually in NMO there is a long segment involvement. So it is called as longitudinal extensive transverse myelitis. It involves more than 3 vertebral segments. So mostly involves cervical cord. So it was a case of NMOSD with bilateral optic neuritis, which was predominantly on left side, then right. So how we diagnose this NMOSD? So there are diagnostic criteria. So there should be one core clinical characteristic should be present. They are optic neuritis, longitudinal extensive transverse myelitis, area posterium syndrome, etc. And we also need to show there is a presence of anti-aquaporin 4 IgG and exclusion of alternate diagnosis. So we diagnose using this criteria. So just to differentiate the finding, multiple sclerosis, NMO and MOGD. The NMO and MOGD share some similar characteristics, except that MOG has a good visual prognosis, whereas NMO has a poor visual outcome. So multiple sclerosis mainly unilateral disease, NMO unilateral or bilateral, and MOG usually bilateral, and it is short segment optic nerve involvement, whereas NMO and MOG has a long segment involvement, and white matter I have discussed already. And in cord, usually it's a peripheral cord involvement, usually short segment of a cord involved, that is less than 3 vertebra in case of multiple sclerosis. But in MOG and NMO there is long segment of cord is involved, which is more than 3 contiguous vertebra. And the cervical thoracic predilection is there for NMO, and whereas MOG it is cauda equina. So coming to the case 4, it's a known case of neurofibromatosis type 1. It's a male child, 9 years. So we have only a non-contrast image. This is a stir image, T2 weighted. Here we can see the left optic nerve is bulky and it's thickened, and it's showing torture scores when compared to the right side. So see at the sag coronal oblique, the optic nerve is showing similar finding. The intraocular in an intraorbital part showing tortuosity as well as thickened, whereas the optic canonicular and prechiasmatic part is normal. So in this case we see some white matter abnormalities in basal ganglia and thalamus, and also in the midbrain. So these are called focal areas of altered signalinity in case of neurofibromatosis. So this was a case of neurofibromatosis with left optic nerve glioma. The NF1 is diagnosed using the diagnostic criteria. There are many features there to diagnose NF1. And coming to the 5th case, this is a middle-aged female. These are the core stir image. See at the left optic nerve, it is thickened, and it is showing hyperintense bright signal. This is a T1 weighted fat side image. It's a non-contrast. See at the optic nerve, it is also appears thickened when compared to the left side. So on post-contrast image, the optic sheath is enhancing homogeneously and the optic nerve per se is not enhancing. So it is giving appearance of tram track like appearance. So this kind of appearance not typical for meningioma. Other kind of perineuritis that inflammatory and infectious cause also give this picture. However, in meningioma there is progressive vision loss. There is not sudden onset. It's an insidious onset vision loss. But in case of perineuritis, there will be a painful eye and there is sudden onset of vision loss. So this was a case of left optic nerve meningioma. Just to differentiate glioma and meningioma, glioma usually seen in first decade. So whereas optic meningioma mainly seen in middle-aged women. So in NF1, the optic gliomas can be a bilateral, and in children's meningioma can be bilateral. Just to differentiate features between glioma and meningioma, the calcification is more common in meningioma, which is seen in 20 to 50% of cases. No calcification in optic nerve glioma, and the nerve per se is not distinctly seen from the lesion. But whereas in meningioma, as we saw in the case, it is distinctly seen and it is giving appearance of tram track like appearance. So these are the differentiating points of glioma and meningioma. So coming to the differentiating demyelinating and neoplastic. So demyelinating mainly cause acute kind of sudden onset monoocular loss, whereas neoplastic they are painless and cause proptosis as well. And usually they are in demyelinated condition, the pain arises on eye movement, and they show relapsing and remitting type of course, whereas neoplastic are mostly stable. So coming to the last case, so this was a middle-aged female with complaints of headache and vision loss. These are the stir images, T2 fat side image. Look at the optic nerve sheath, they are prominent, and also see the optic head, they showing protrusion. So this is equivalent to that of papilledema which we see in clinically. So we are seeing bilateral optic sheath prominent and protrusion of optic head. So these are T1 weighted image. Here we can see the empty cella. So we can hardly see any pituitary here. So it is an empty cella. And these are the venographic images. This is a sagittal sinus, and these are the transverse sinus, and this is a sigmoid sinus. See at there is a narrowing at the sigmoid and transverse sinus junction. It is involving bilaterally. So these are the four features: flattening of posterior sclera, prominent sheath, empty cella, and stenosis at the junction of transverse and sigmoid sinus. So in this was a case of idiopathic intracranial hypertension. To diagnose, it is mainly as ma'am said, it is modified Dandy criteria is used to diagnose. However, in absence of papilledema, the features on MRI, out of 4 I have shown, if 3 are present, then we can raise a probability of IAH to the clinician. So these are the references. Thank you for the patience. Thank you.
Thank you, Dr. Sharath. If anyone has any questions or any comments. Yes, please. Mike.
How do you manage that case, ma'am? Because we cannot give Diamox as it is teratogenic.
I completely agree. We just
and the pregnancy itself aggravates the
few days we saw such kind of case few days back. So it depends. If the vision is maintained good enough, maybe you can choose not to do or just to observe. But if vision is affecting, you will have to do some intervention, probably surgical intervention, and that's what we did with that patient.
Okay, ma'am. Ma'am, actually during my post-graduation in Aravind Eye Hospital, they just suggested to abort the baby. So is that an option to save the eye?
That is not my call to take. I think that will be a patient's call entirely how they want to go about it. Yes, in extreme cases, if the vision is quite severely affected and there is no scope of any surgical intervention also for that matter, maybe in such a case, but I would personally never, take that call.
Okay, ma'am. Thank you.
Anything else, any other question or comments? So thank you, Dr. Sharath, for that wonderful presentation. So radiologist will give you as much as information you give to them. So for that you have to be very thorough with your clinical examination, learn to localize those lesions, and then you can ask for a tailor-made neuroimaging to guide a radiologist what to look for. Otherwise you will keep on doing neuroimaging one after the other and will not have any answers to your questions. So with that we come to the end of neuro-ophthalmology session. We have a very interesting talk next by Dr. Amar, who is going to give a kind of virtual hands-off. So hands-off, which is a video based, and he will be telling us about how to do an orthoptic workup properly. You will also get the practical hands-off of the same in the lab, in the Squint lab, and also in Neuro-Phthal lab. So you can have one-to-one interaction there after the lunch. If you have not registered for the same, you may please give your names to Dr. Himani, please.
So
Thank you.
Those of who have opted for it, we have listed out them, and anybody who's interested can post lunch. We'll just announce we are around 2 or 2:15 probably. Everybody can collect here, and we'll take you from here down to the orthoptics, strabismus, and neuro-ophthalmology lab. So we'll divide you into groups so that you can be led there. So hopefully we'll be finishing in about 15-20 minutes more, and then we'll break for lunch, half an hour for lunch, and then we'll collect here for all those who wish to go down and have a look at the labs. We'll divide them into groups, and they can actually go and see the hands-on working of everything that's going on. Dr. Amar, please.
Sir, thank you, ma'am. So this is a video. You can just observe the things, so how the tests are being done, and what are the doubts you have, you can just clarify doubts, right? Voice.
Easily, like in this case, the patient is a case of exotropia. If the Hirschberg test is present temporally, then it is a case of esotropia. Coming to the extraocular movements, for every patient, versions as well as ductions need to be observed. The patient is given a distance target, which could be a visual acuity symbol of more than 6/12 or a near target like a Lang's target. Then the target is moved in all the cases to look for the limitation or the overaction of the movement. Here we can see that the target is first moved to levo version to look for the lateral recti and the medial recti, and then the dextro version. Then the patient is asked to look elevation followed by depression to look for any pattern as well as vertical recti. Then the patient's eye is shifted to levo elevation to look for any right eye inferior oblique overaction, and dextro elevation for left eye inferior oblique overaction or underaction. The patient's gaze is then moved to levo depression for right eye superior oblique underaction overaction, and dextro depression for left eye superior oblique elevation or depression. Coming to the cover test. A cover test is done in cases of tropia, and a cover-uncover test is done in the cases of latent squint or phorias. In cover test, the fixating eye is covered with a or a palm, and the movement of the non-fixating eye is seen. The opposite eye will come to take the fixation. We can see here that on covering the left eye moves up and out. On covering the right eye, the left eye comes to take the fixation. Since the movement is from out to in and up to down, there is exotropia as well as a component of left eye dissociated vertical deviation. The prism bar cover test is done to measure the amount of squint. A prism is placed over the eye and an alternate cover test is done. the movement of the eye is seen and the prism of increasing strength is placed over the eye till there is an absence of movement or a slight refixation movement in the opposite direction. At this point, the amount of squint is said to be neutralized. Here we can see that there is a component of vertical as well as horizontal deviation. So first, the horizontal deviation is neutralized. Now the movement is only vertical, so a vertical prism is placed such that the apex is towards the deviation. Here the apex is placing upwards on the left eye. We can see here that there is an almost absence of the movement in either of the eyes, indicating that the deviation in the vertical as well as horizontal direction has been neutralized. In cases where there is low visual acuity or deeply amblyopic eye, the patient cannot fixate on a target. Thus, a crude test is utilized where the corneal reflex is neutralized till a prism of increasing strength is placed on it. If the prism is placed on the fixing eye, it is a Krimsky test, and if it is placed on the eye with the low vision, it is known as the modified Krimsky test as shown here. Hess charting is done based on the haploscopic principle and the principle of foveal projection. A mirror is used to dissociate between the two eyes. There are two screens known as Lee screens that are shown here. One screen is lit and the other is not. The patient is then placed onto the chin rest and the eyes are dissociated. The patient is explained the procedure, following which one of the screens is switched off and a patient is shown a dot with a marker, which has to be then shown onto the screen which has been switched off. To confirm and record, we light the screen and record it onto the paper. The eye with the primary limitation will show a smaller field and the curve of the dots will become smaller, with the greatest amount of reduction in the area of the paralytic muscle. Stereo acuity testing is extremely important in strabismus. For distance stereo acuity, tests like Frisbee-Davis distance test and distance Randor test can be used. In FD2 test, real targets are shown to the patient. These targets are stuck onto the stick and placed on a screen. We can see here that the subject is placed at 6 meters from the Frisbee-Davis distance test box. From the side screen, the targets are moved such that one of the target is moved anteriorly and the amount of movement is shown by the calibration on the stick. The patient is then asked to recognize which target is placed anteriorly, and depending on that, the amount of stereo acuity graded. Distance Randor test is done based on the principle of vectographic principle. After giving full refractive correction and the Polaroid glasses, the patient is asked to sit at 3 meters from the book and targets are shown in the form of geometric figures with decreasing seconds of arc and increasing stereo acuity, and the patient is asked to recognize them on a random dot stereogram. Similarly, a near Randor test is done sitting at 33 centimeters. As for any case of binocularity and stereo acuity, full refractive correction and prismatic correction is required before giving the patient Polaroid glasses. The patient is asked to look at the R and the L to confirm binocularity, following which gross stereopsis is checked on the right side of the book using geometric forms. Once that has been confirmed, the patient can then go on to look for finer stereo acuity. The animal charts on the left lower part of the book are used for pediatric testing and go from 400 seconds of arc to 100 seconds of arc. The graded circle test in the upper left part of the book is from 400 seconds of arc, that is used for adult fine stereoacuity testing and can give an idea of the amount of near stereoacuity of a patient. A complete orthoptic workup is a must in every case of strabismus.
Thank you. Any questions anybody has? Of course, the practical demonstration will be held when we all go down. So, any points to make or anything to comment? Dr. Amar, please, if you have to add anything.
That's it. It is very important to have these investigations because, especially in case of IDS, when you want to decide for surgery, so we have a clinical scoring system, how many times the patient is deviating. At the same time, the intention of surgery in squint is to restore the binocularity, so that's why we want to assess the near and distance diopters. So once patient is deteriorated distance diopters and he is at the risk of losing the near diopters, that is the ideal time where we want to correct and we want to restore both the near and distant stereopsis. So at the same time, doing prism bar cover test, other stereopsis test and other investigations in strabismus, including H charting, diplopia charting, are very important because we will get to know, because giving a maximum binocular single vision field is very important, as sir was telling in the morning. So majority times we focus in the primary gaze and the down gaze, where we want to create a comfortable environment where patient can work, right? So you can get all these testing things downstairs. So you watch the videos, this is a trailer, so you can go there, you can pick up the instruments and you can pick up the things, you can test for yourself, you can test on other colleagues, so you can get to know how the random dot stereopsis works, how the FD2 works, how the prism bar being placed, right? So you can get all these things on yourself. So just try to see how the things are appreciated. If you learn, then you can tell it to the subject, right? So that is one way. Let's see for ourselves. So then only what patient is saying, okay, what he is saying, whether it is true or not, we can just get a clear idea upon that one, right? Thank you.
Thank you, Dr. Amar. Thank you everybody for the wonderful sessions we've had in the morning. We'll break now for the most important session of the day, which is lunch. That will be available in the 6th and the 7th floor. And I think we can, for all those who are interested to have an orthoptic visit, we'll assemble here at 2:15. So lunch is available 2:15. All those who want to go down can come back here. We'll divide you into groups and we'll take you down. Thank you. तुम इधर डर के क्यों भाग रही हो? All faculty please up for a group photograph.
फोटो तो आगे खींचेगा ना, यहाँ हटेगा प्रोजेक्ट, आगे खींचेगा फोटो यार। अरे प्रोजेक्टर बीच में आएगा ना, बताओ प्रोजेक्टर को।